Good morning, everyone, and thank you so much for joining us today. We are extremely excited to have you here at our first hybrid conference, and this is an opportunity for all of us to learn from each other. So there's some housekeeping that I would like to kind of share with you to make sure that this conference will go smoothly. One of the things that we'd like to ask you is to turn off your cell phone or set it up in vibrate. And we have several breaks throughout the day, so you can check your emails and text messages later. We will record this conference and make it available on our website in the next week or two. And we also have coffee stations, so please feel free to help yourself throughout the day. And we have virtual attendance today that probably we need to remind everybody that if you'd like to take, if you have some questions, please use the raise hands icon or type your questions in the chat box. So without further ado, please welcome Professor Casey Mulligan. Thank you.
But yeah, I want to start out. I'm wearing two hats. My first hat will be kind of lay out the vision of the conference, and then present my piece. The the national debate and a lot of research policy effort around healthcare. Tom and I at least think that it's disproportionately about who pays, getting those insurance cards in people's pockets. And in the process may have undermined the availability of healthcare now and in the future. And that's why we wanted to have a supply-side health economics conference. And we wouldn't be able to do this without a lot of help. If you've met Sri, she's organized this in an amazing way. I saw from the econ department, Madison was here, and Jessica I saw earlier came over to help. The Harris School made a contribution to this conference. We appreciate that. The booth, the healthcare initiative over at booth, and also their applied AI group made a contribution. And we have our research team here taking time off of coding, which is fun stuff, right? But off to help also to participate, and we hope to hear their insights as well. So maybe I put it a little too bluntly, but this obsession about who pays, I think of that as an instance of the classic error of utopianism. That not only does it just assume great numbers of chickens, if you heard that Soviet saying, assumes great numbers of chickens, but also that the chickens can and will fly directly into people's mouths, already feathered and cooked. No, healthcare has to come from somewhere. It needs to be supplied. Who supplies healthcare is quite critical. And so today's program is organized around some of the most important elements of healthcare supply. One of those would be the manufacturing of drugs and devices. And we have a talk today by Alison about weight loss drugs. Moiz is here. He was going to talk about policies related to the supply of healthcare workers. Very important. And we shouldn't forget the patient. The patient's not legally an employee, but they're maybe the most important laborer in the healthcare process. And we may be on the cusp of innovations that have the potential to help patients be more productive. And those are especially artificial intelligence tools that can help the patient have more medical knowledge and make better medical decisions when they're at home, when they're with their family. But we also expect, of course, companies to use the new AI technologies too. So we're going to have both of those perspectives come up today. Tom will give a talk on AI, especially on the company side, and also Joe Grogan, who's going to join us virtually. Now, did anybody miss the or notice the misspelling in the artwork? Giuseppe noticed. Good. That's a metaphor for messing up the little things that can undermine an entire enterprise. A big problem, not the only, but a big problem with a centrally planned system or a system that prohibits profit. It removes the incentives to make the necessary but mundane contributions to supply. And things like getting the spelling right is quite a mundane thing. It's not glorious. It's not something a politician wants to pursue. But we need those mundane things. And that kind of leads to my contribution to the conference, which is to talk about the boring business innovation. I hope my talk's not boring, but business is much less exciting than discovering new chemicals and things like that. So let me turn to the presentation on business innovation. And one of my main examples you might have seen on the program refers to buyers clubs. One of my main examples is of business innovation is buyers clubs. Yeah, that was right. There we go. Yep, that's the one. Okay. One of the challenges for humanity is funding intellectual property and making it available. Of course, we know, we've seen this in economics a lot, creating intellectual property is a fixed cost, meaning it doesn't matter how many people use that knowledge, the cost doesn't really vary with that. It's obtaining the knowledge that creates the fixed cost. So who's going to pay that fixed cost? One idea, it's very common in economic models. I actually don't think that common in the marketplace, that each consumer pays in proportion to the amount used. And a problem with that is it leads to underutilization. The people, when they purchase a product, a new product, they're not only paying for the cost of making that instance of the product, but they're also having to pay for the intellectual property. And so they purchase too little. Another strategy in economics known as two-part pricing would be have some kind of membership fees that are not so tied to utilization that finance the fixed costs, and then people pay the marginal cost to the extent there is one on those new products. And then a third strategy is Ramsey pricing, a multi-product firm. And the idea there is, well, if we're going to have to recover that fixed cost by charging people in proportion to what they buy, maybe we can recover it on the goods where the underutilization won't be such a drastic problem. And that's called Ramsey pricing. And we see that very much in healthcare. Again, gets ignored so much that the health insurance company is delivering many products. One company, many products. Pharmacy benefit manager, which I talk about today, they are dealing with many different drugs, and they can recover the fixed costs for drug B through their charges on drug A, if that might lead to less underutilization. And this gets forgotten a lot. And it's funny because when we talk about underutilization, one of the classic things in economics, not just health economics, is insulin. Well, the demand for insulin is not very price elastic. Great place to recover fixed costs. And we see the market doing that sometimes, and that's made a lot of press. But the economic analysis hasn't quite reflected that, wait a second, we got to recover the fixed cost somewhere. Maybe insulin's not such a bad place to do it. figuring out how to do these things is not easy. We're not born with that knowledge. It needs to be discovered, and that's the role for entrepreneurship. One of the challenges for entrepreneurs, if you're going to do a two-part pricing scheme, for example, how are you going to prevent members from reselling to non-members? If your scheme is have a membership fee, and then you can buy these healthcare products very cheaply at the margin, maybe I should buy not this enough for me, but for other non-members and resell it to them. So you have to deal with that. Now you might say, well, that sounds kind of strange, but remember, an individual can be a member at some times and a non-member at other times. So they can do that with themselves, so to speak. There's the question, who are the members going to be? And I'm not referring to the Groucho Marx joke about being members in clubs, but there's the question of who, if we're going to recover the fixed costs and try to have the fewest economic distortions, what's the right group to bring together? And then in the multi-product approach to things, which products are going to be sold together? And there are companies doing all these things at the same time in different combinations that are constantly discovering better ways to do it. Okay, I'm going to refer to a concept from microeconomics called the core. Really, the background for why we want to think about the core is we do so much in groups. We're a group here today, right? It's even rare for people to live alone. Now, somebody might say, wait, I have my own apartment. Well, but you're in a building and you're sharing snow shoveling, maybe a gym, parking. So it's rare even to live alone. We're doing things in groups. And I think when without getting into some ideas of the core, we're missing out on that fact. We're modeling individuals. That's not how we live. We don't live as individuals. We live in groups. And you think about, I think we had roughly 50 people engaged in the conference right now between online and in person. How many ways could we arrange? Just 50 people. I'm not talking about all 300 million people in America. How many ways could we arrange us in groups when we're in the break time? Some of us will talk in pairs and threes, fours. How many ways can you do that? Anybody know? It's literally an astronomical number. It is a bigger number than the amount of centimeters from here to Pluto. When I was a kid, we called it the planet Pluto. I guess it's not a planet anymore, but it's still there. And it's a lot of centimeters away, but the number of ways we could arrange the conference participants exceeds that. There's no way a bureaucrat can even begin to list the possible ways that we could organize together, let alone assess which ones are the best. And this is why a very important part of supply would be the market, that we have people organically forming groups, joining groups, quitting groups, joining other groups. This is incredibly important. We see it happening. So the definition of the core is if it's allocating the resources in the economy in a way that can't be improved by any coalition, which means taking a group of people and say, we're going to quit our existing groups and form a new group. And there's that's the formula I use to show that it's more than the number of centimeters to Pluto, 2 to the n being 50 minus 2 possible ways to do it. And these coalitions are organized with voluntary membership. This is extremely important. The voluntary part, that's how you're going to make improvements, because there's which one of these 2 to the n minus 2 are we going to pick? We have to let people try new things, join new groups. One of the reasons why I find health insurance mandates to be problematic, because they are forcing people to be in a group rather than having it a subject of choice, which is really the engine of progress. So let me give an example now of a particular type of group. I already alluded, there are lots of groups, families, people who live in an apartment building together. But one of these groups that looms rather large in the supply of healthcare would be buyers clubs. You might think of Costco as a buyer's club. They actually are involved in healthcare, but they're a buyer's club for skateboards and lawn chairs, tents even. But they form a group to negotiate with the manufacturer. And these groups can be a small set of consumers. You don't want to be confused to think that, well, the way a buyer's club work is it's really massive. And it really puts pressure. You can put pressure on the manufacturer just with a small group of consumers. An example of that I'm sure you've run into, maybe you hadn't noticed, would be this sale of soda. Whoops, I spelled soda wrong here. S-O-D-A. The reason I spelled it wrong because in Illinois we call it pop. I never even use that word, but if you go to the restaurant, very many restaurants only offer Coke or only offer Pepsi, right? You've seen that. Oh, may I have a Coke? Is Pepsi okay? Well, why are they doing that? Are they trying to make the Coke people upset? No, what they found is if they tell Coke and they tell Pepsi, look, I'm only going to carry yours if you give me an awesome deal. And that deal is passed on to the consumer. Even small restaurants do that. That's my point. The restaurant across the street from my house, they only offer Pepsi. This is a small restaurant. I mean, the lady owns 2 restaurants. She's not like McDonald's. She's not 1/1000th of McDonald's. She doesn't have the massive power of size, but she has the power to say, look, you can have none of the people in my restaurant or you can have them all. Give me a deal. And that's really the essence of the buyers clubs. And this is happens in healthcare a lot. Insurance plans are an example. They serve various functions, such as the financing, but they also serve the function of negotiating. They'll negotiate with the hospital and they'll say, look, you can have all the people in my plan or none of them. Now, it's not quite that extreme. They'll put it in different tiers. Again, that's part of the innovation process. But even a small insurance plan can get a good deal from a hospital by giving them that all or nothing option. And then people want to join these plans. Just like I want to go to the restaurant across my house. I don't like Pepsi. I don't know what we have here today. I prefer Coke, but I still go to that restaurant because what they've been able to assemble is not exactly tailored to what I want, but it's still better being part of the group. A particular, I mentioned one example, health insurance is a buyer's club. Now I want to talk about drug insurance, it's a particular type of insurance that's covering pharmaceutical prescriptions. And the idea that was discovered in my lifetime, not so long ago, was that, if we're going to have insurance, maybe we want to manage it. We don't just want, even though the textbooks still model it this way, we don't just want to tell the consumer, look, here's your copay, here's your premium, come and purchase your pharmaceuticals if you so choose. It was decided that, we should manage this a bit. We should manage what people are purchasing and how much. And we can use that to make the premiums cheaper or to make people healthier or some of both. And it'll turn out, I will show you how this particular type of buyer's club has begun to solve the problem of paying for the fixed cost. The very thing that I started with today about, well, how are we going to cover fixed costs? Buyers clubs can do an element of that. It may be a little surprising because we think of these buyers clubs as trying to squeeze the manufacturer, and they are, but they also end up recovering substantial fixed cost. I had a piece, I'm not going to go through that piece today, but where I tried to look in the various aspects of buyers clubs for pharmaceuticals, and the buyers club process was worth $145 billion a year in the United States, net value added, over and above the value of having the drugs. Of course, the drugs, new innovative drugs are nice too, valuable. They induce the suppliers to compete more vigorously with each other. And plans end up getting better utilization at a lower price. And this is kind of the, this middle part is the trick for recovering the fixed costs. getting better utilization, more people using the new therapy can help recover fixed costs, because the more of us that share the fixed costs, the cheaper it is for any individual. Okay, so here's I would say a supply and demand picture. It's mostly a demand picture of how the Buyers Club can work. So on the axis, I've drawn in the usual economics way, quantity on the horizontal axis, price on the vertical axis. Since we're talking about prescriptions here, number of dispenses, I'm going to express it on per member of the plan, and the dollar per prescription. I've drawn in here an iso-profit curve that will allow the maker of the drug to recover the fixed costs. They could recover the fixed costs if they sell to a few people at a high price or a lot of people at a low price. In some sense, the manufacturer doesn't care. What they want is a profit. They want to be able to recover enough profit to recover their investments. And in equilibrium, they'll of course anticipate this process. So they're only going to make the types of investments that they can recover somehow. Now, if they had an unmanaged benefit, meaning that quantity and price were just determined by the demand curve, there's a price, and then the patients just choose on their own, we might end up at a place like this. But the idea of Buyers Club is to say, can we improve on that for our members? Non-members won't participate in this, but our members will. And we can see lots of points that improve on that. Say that point at the red dot. That red dot also recovers the fixed costs, but it has more utilization and has Q1 rather than Q0. What is that worth? Well, we can measure it geometrically as the area under the demand curve and above the marginal cost between those two quantities. So that's when I said there's 145 billion, a significant chunk of that comes from moving that quantity out. It's moving it off the demand curve, and this is creating this is one of the challenges of running it. So we have two prices here. We have the net price that's being paid, how much the manufacturer is receiving per unit quantity, but the club has people consuming at Q1, so they're presenting the members in effect with a price that's lower, the lower marginal price. Now we get into the problem here, the challenge with a Buyers Clubs. How are you going to stop the members from buying at this low price and selling it to people at the higher price? Remember years ago, Tom and I talked about this around government programs, and we thought, well, people would laugh at us when we say that. Then we had the opioid epidemic where people were doing exactly that, buying at a low price, actually a government subsidized price, and selling to others in their neighborhood. People died from that. But even
it's illegal with prescription medicine, but people can do it.
It happened millions of times.
It's illegal, but it's feasible.
I know that. It's not just feasible, it happens. And this can be and less, it wouldn't be illegal, for example, if I was on the plan for a year, I stored up my pills, and then I went off the plan. And then I used my pills that I stored up. That's the same arbitrage. When I'm on the plan, I'm buying at this. And when I'm off the plan, as a non-member, I'd have to buy at that higher price. And if I've been able to do that. So that's one of the challenges with managing the benefit. How are you going to have two prices and without having any counterproductive behavior going on? So I draw an additional cost in here. There's a marginal cost, not just for making the drug, not just the manufacturer costs and the normal distribution costs, but you have to run this operation. It's going to take people. Sometimes they may have doctors that work for the insurance company who kind of look at the patient situation. Are they taking the right amount? Are they taking the right prescription? That costs. That's a cost. There's also opportunity cost. There's some of the people like me who's getting the Pepsi when he wants the Coke. because the plan may be carrying one of these drugs and not the other, and the other drug might be a little bit better for them. And you hear a lot of these complaints in the press, and that's a cost. I count that as a cost. But there's an offsetting benefit that helps us as a club do better. So the way I get to an equilibrium here is, well, we move down that recover the fixed cost curve to the point where the marginal cost equals the marginal benefit. And that's why the equilibrium is not Q1, it's Q1 rather than some larger quantity and rather than some smaller quantity. And one of the things that's happened over time is that companies have discovered better and better ways to do this. As they've gained experience, technological change, maybe they'll be using AI as well. I haven't heard that directly. So these red dots have marched out to the right. Oh, before I march them out to the right, I should note there's a term of art in the industry called the rebate. The rebate is the gap between what the non-members pay and what the members pay on average. And we're going to track that as well. So as this industry has progressed, the red dot moves out to the right. More utilization, more surplus, also a bigger rebate. And this is one thing we've seen over time in this industry. The rebates have gotten bigger and bigger and bigger. That's a sign of progress. Or maybe I'll put it another way. If there were progress, that would occur. So there's one step, maybe another step. You see the red line is rotating. That's meaning they're figuring out cheaper ways to achieve these objectives. And therefore they can pursue the objective more. Okay. There are 4 prices in this market, and this is what creates some of the challenges that I've alluded to. There's the list price, the non-member price. There's the net price, which I showed. I'm going to call that P, total expenditure divided by the quantity. There's the marginal price, which is even lower. And then there's the marginal cost, not counting the marginal cost of running the buyers club. So we have 4 prices lined up in order. Here they are in the picture. I put a red box around each price. There's 4 prices going on. I point that out because when we're studying these markets, we need to understand there's more than one price. This is why you need graduate school. An undergrad, supply and demand only has one price, right? You got to have graduate school where we can handle 4 prices. And anytime we're measuring prices in markets where they're doing this kind of volume discounting, we need to understand, which price am I measuring? Is it the marginal price? Is it the non-member price? Is it the average, the net price, the marginal cost? These are all different. And the theory has a lot to say about how they relate to each other. Give an example. It's called, again, this is a pejorative term. It's called the rebate trap. And what they're referring to is that the volume moving out to the right here is implemented by a rebate that is tied to the quantity purchased. So what the manufacturers and the plans agree to, they say, hey, plan, the more you purchase, the bigger rebate you'll get. The bigger that gap will be. And that's just moving down that blue curve. So to do a little arithmetic here, what's paid in total is on the left, the net price times the quantity. And the net price is the non-member price, the list price, times 1 minus the rebate rate. And the rebate's the percentage discount you'll get off the non-member price. And that's a function of the quantity. So what's the marginal price here? We know how to do this. Undergrads know how to do this. Some high school kids can do this. It's a first derivative with respect to the quantity. So that's what I've done here. And that's the marginal price that I showed in the previous diagram. And it has 2 terms. The first is the net price. That's part of the marginal price, but actually it's a discount at the margin. And it has to do with the fact that when I buy more, I get to save more on the drugs that I already purchased, that I was purchasing even at the lower quantity. And that's why in the picture, the marginal price was the third lowest of the three. Non-member price, net price, and then below that, the marginal price. And this is called, in the industry, by people who don't like the system, they call that a trap. Because they say, wow, plans are purchasing these drugs rather than generics because their marginal price is so low. Yeah, that's the whole point of making is to make the marginal price low. Okay, so we covered that. Now, how can drug innovation be rewarded with this? The innovators are the manufacturers, or even upstream from the manufacturers. So you would think, well, if the manufacturer has this buyer's club that's kind of squeezing them, how can they make enough money to innovate? Well, let's look at the different phases of drug development. And my horizontal axis here is time from the patent. So there's some initial time, unfortunately, where there's no cash flow to the manufacturer because they got their patent, but they haven't been approved by the regulators to have their drug in the market. So you have that phase. And then finally they get approval, and now they start to get cash flow. And at first, in the early phase, the cash flow is pretty good because they invented this new drug and the other companies haven't come up with theirs yet. Buyers Club has a little trouble squeezing such people because there's not a Coke and Pepsi choice. There's just a Pepsi choice or just a Coke choice. And so the main thing that happens in my picture, my demand picture, is we're moving to the right, but we're not moving down a whole lot. We're moving down some because the consumers need to be given a reason to expand their utilization. So utilization is expanded in this phase. And the manufacturers love this. I can tell you this firsthand. I've been to a conference where a pharmacy benefit managers, and there was all these manufacturers. I'm like, what are you guys doing here? Oh, we got a new drug coming out, and we want to make sure that on day one that the FDA puts the thumbs up, that we have lots of patients getting our new drug. And the PBMs are the key to that. And then there's a later phase. Once Coke is there, enjoying being the only one, and then Pepsi comes along. Now the buyers clubs, the buyers clubs are moving to the right, but now they're really moving down. Manufacturers hate that part. So you can see in the later phase, there's a loss to the manufacturers. And what I've done is try to see, well, which one dominates in present value? And it turns out the first one dominates in present value, in part because the first one comes earlier in the investment project. And then there's a generic phase, which I'm not going to get into generics today.
Is the trade-off that you get a bigger market quicker with the PBM?
Yeah.
And then you get nailed on the price.
Yep. Well, I mean, it's a trade-off in the macro sense. I mean, there's a 5 up there. Okay, this is working good. Yes.
And there's no other way of ensuring a quick market than buyers club.
Like I said, they were at the conference voluntarily and happily. I mean, they could send out their own salesmen and try to ramp things up. And that instead of this curve starting out high, it would start out low and start to build. And then next thing you know, Pepsi's there. I mean, you don't want that. You don't hear this, I know, because the manufacturers don't want you to hear it, but that's how it works. Okay, let me give it another example of fixed cost. One that we can remember because we had an infectious disease going around a couple of years ago. There are always ones going around, but ones that we really noticed went around a couple of years ago. It was kind of like the flu, more severe than the flu, but it had many features of the flu. So I want to start out talking about the flu using pre-COVID data. And I was wondering, where do people get the flu shot? It turns out a lot of employers offer the flu shot, including our own. You've probably gotten the emails on the days and times when you can get the U Chicago flu shot. Among people who are employed, naturally, people who don't work for the University of Chicago don't come to Chicago for the flu shot, although we do have a hospital, they may do that. This is a very common place to receive the shot. If you look at which businesses and which employees were getting the shot at work, the smaller businesses weren't even offering it. Because naturally, this is again a scale economy kind of issue. We have a fixed cost. We're gonna have, they call it an occupational nurse who's trained to give people the jab, and he or she needs to be paid. And we can spread that cost among a lot of employees in a big company, and so big companies do it. Another example would be sick leave. Can we have a formal program to encourage people who have an infectious disease to stay home? And it's very common to have sick leave, again, at the bigger businesses. Okay. So what I did in a study relating to COVID, I looked at, well, how's it going on preventing the spread of COVID at work? Now, the pure medical people who don't do economics, they said, oh, big groups are bad for spreading disease. Stay home. But they weren't thinking about the economic sides, like big groups are good because we can spread fixed costs over more people. We also have greater demand. When I'm in a big group, maybe it doesn't affect me wanting to prevent, but I would really like all my coworkers to prevent. So I did some study. I looked at the Duke Health System, where I could look both before they put in prevention measures and after, and they were open all the time. So, and we see before they put in prevention measures, a lot of spread happening in the Duke Health System among the employees. After about 2 weeks, they put in prevention measures, and it went much lower down. One means here the rate of spread outside of work, at home, I guess, or wherever people went when we were told to go home. Same thing in schools. Schools were very safe places to be if you measure safety in terms of spread of this infectious disease. So this is again an example where organizations can really do some amazing things if we allow people to experiment and try these things. So thank you for your attention, and I look forward to other aspects of the supply of healthcare today. Hello.
I mean, what is the general relationship between the infectious disease one and the virus club? Their groups and fixed costs. What's the relationship?
Well,
Their general level.
the thing about employers, the firm in general, even if it doesn't have employees, but typically firms have employees, firm in general is there to deal with some externalities and fixed costs. That was cost, even if there were no diseases, right? So we've already assembled, we're already kind of good at it. We have a president and a provost who are kind of trained in how to do these things. And then you have a new externality to deal with. It might be a good idea to use the old institutions who've already proven it could be able to assemble a group and deal with the cheating and monitor. And the idea that we would close all those institutions who were built to solve externalities because of an externality was, I find, a ludicrous idea. That's what we did.
Different, I guess, when you have masses of people that are not, they're not internalized. So if you don't have an organization, so yeah, you know, if you have a.
That's called staying home.
No, that's one aspect of it. Also, you know, if you just have people going out to, I don't know, restaurants internalize their clients and stores internalize their clients. But it's harder than it works, but you can't make as much demand.
Yep. But they're smaller organizations, and we knew that before COVID. I showed you the data. The kind of flu shot in the small companies. You know, a lot of restaurants probably didn't have flu shot set up for their employees, right? The smaller restaurants. McDonald's probably has a flu shot program. They're a big company.
But the bottom line for you is that the larger the group, the safer, the lower the impact,
Yes,
as opposed to epidemiologists who say that.
yes. They did say the opposite.
Trust me, I know.
Thank Alison.
Are we doing virtual next one?
If there's any, I mean, if there's any more questions, whether it's in the room or online, we still have like 13 minutes for you, Casey, so.
I'll ask a question on, so various states have been passing legislation to ban the rebates. Where do you think that the rebate is going to be captured? Is it going to be kept at the PBM level? So is there going to be an unintended consequences of state regulation on PBMs where they prohibit rebates back to the buyers?
Yeah, you're right, there are bills and proposals to ban rebates, and some states have engaged in that very recently. You might have gleaned from my discussion, who do you think would be in favor of banning the rebate? I mean, go to my restaurant example. Coke really doesn't like that Pepsi's offering those rebates, and Pepsi doesn't like that Coke's not offering the rebates. If they were to get together and say, let's agree with each other not to do rebates, they'd go to jail. I mean, that's a Sherman Act violation. But if they can get the government to do it, more power to them. That's what's going on. We saw that very clearly when the White House was considering, when Tom and I are in the White House, considering the banning rebates in Medicare. The biggest proponent was it was a former president of Eli Lilly, right? It's not specific to healthcare. That's why, Tom and I are kind of pushing the economic analysis in general, like Onglin's has IO work and he has health insurance work. I mean, the same principles apply, and we see capture of regulation, regulation used to stifle competition in all kinds of things in healthcare.
You guys, thank you so much for having me today and letting me talk about our work on modeling the benefits of coverage for weight loss drugs. I think that the order of today is so perfect, at least for my presentation, because I think we'll have a lot of fun talking about weight loss drugs and all of the hype around Ozempic and stuff like that. But really, the framework that we're using to look at the benefits of coverage is not at all new to weight loss drugs, right? So the initially high list prices and the hysteria around budget impact and stuff like that is not new to weight loss drugs. And my colleagues at the Schaefer Center, along with Tomas, have been studying and talking about this stuff for years and looking at it within hypertension, HIV, Hep C, and many other drug instances. So today we'll focus on weight loss drugs, but this same idea expands well beyond just weight loss drugs. So am I able to advance slides from here?
Yep. That's the next one.
Okay, so the work that I'm going to share today, the results that we'll talk about and stuff like that are all from a white paper that my colleagues and I at the Schaefer Center put out last spring, modeling the benefits of Medicare coverage for weight loss drugs. And I've added in a few extra set of results so we can sort of talk about more broad access in general. And then if we, is this, okay. So the game plan for today is to just cover quickly the current state of the obesity epidemic in the US, then touch on some of the policies impacting the insurance coverage for these drugs, then go over how we've chosen to model the benefits of broad access or of insurance coverage, then run through the results from that modeling and talk about the policy implications. Okay, so obesity rates in the US have been rising since roughly the 1980s. And I think most of us have probably heard the statistic that over 40% of adults in the US are obese. And so that obesity threshold is really a BMI of 30 or greater. And what we have graphed here is the average BMI in the US. And as you can see, that's been climbing over time too. And we're just hitting the point where the average BMI is 30. And of course, in the status quo, again, without new interventions, this is projected to continue to climb over time. And what's hidden in a lot of these statistics is the fact that obesity disproportionately impacts minority populations. So here we have obesity rates by race and ethnic groups. And so on the far left there, we have obesity rates for Blacks, Hispanics, and whites. And what you see is in the Black population, obesity impacts 60% of adults, whereas in the Hispanic population, it's 51%, in whites, it's 41%. And although that variation is rather shocking, I think what's even more alarming is the variation. We see the variation is concentrated in the higher BMI category. So it's really once you hit a BMI of 35 or greater where we really start to see the disparity across race and ethnic groups. And those are the categories where you have the increased health comorbid conditions like diabetes and heart disease. So it shouldn't be surprising then that once we model these comorbid conditions to obesity, that we see both disparities again in the rates, but also high rates. These rates have been growing over time too, just alongside the obesity rates in the US. And so this is important to note that the previous slide had rates for the entire population. We're looking now at these disease rates within the Medicare population, as the onset of these diseases tends to be later in life. So the graph is a little bit more compelling if we focus on that population. But again, we see the disparities in the minority populations for diabetes, hypertension, heart disease, and disability. So again, we're just sort of creating the story around the burden of obesity in the US right now. What we need to also talk about is not just how obesity impacts the chronic conditions, but also that obesity is associated with shorter lives, reduced life expectancy. And this graph is pretty intense. It's a figure from a JAMA article, but what it's showing us is the years of life lost on the vertical axis associated with each BMI level, where each one of the bars represents a 10-year age range. Lightest is younger and darker is older. But if we focus in here on the BMI of 40, we can see that if you become obese in your 20s or your 30s, having that high BMI is going to be associated with 6 or 8 years of lost life. So there is definitely a mortality impact with obesity. Then finally, as economists, we also want to think about how obesity will impact, I think I'm changing the slide here, health-related quality of life. And so a prior health affairs study looked into this, comparing different sort of ailments and looking at which one had the greatest decrement to health-related quality of life. And they found that having a BMI of greater than 30, again, that's the obese range, what had a bigger impact, a bigger decline in health-related quality of life than aging from 30 to 50. So there's a lot of students I know online and in the room. And so if you haven't hit that age decline yet, we can also look at the comparison between being obese versus being a current smoker and seeing that it's much worse for your health-related quality of life to have obesity versus being a current smoker. So to just sort of summarize all of this, we have this huge burden of obesity in the US, and it's not new. We've been sounding the alarm for decades, and the status quo policies aren't making a dent. We keep outpacing our projections on obesity. And so we have medical associations doing their best to raise awareness, government agencies doing the same. And yet still obesity is oftentimes viewed as a lifestyle choice rather than a disease and a serious health concern. And all of this creates stigma around the patients and the treatment. And uptake of available weight loss drugs has remained exceptionally low. As we have had the introduction of the new GLP-1 drugs, we're seeing a little bit of an increase in uptake. So that 3% comes from, I think 2018 or 19 GAO report. And in the last few years, we've definitely come up from 3%, but it's still very low. And this all feeds from the fact that there's not access to the drugs. Medicare is explicitly excluded from covering weight loss drugs. And then private insurers either, following Medicare's lead or for many a host of other reasons is also often not covering weight loss drugs. So all of this seems rather depressing, but there are a few policy levers available to impact coverage and access for weight loss drugs. And so, as I mentioned before, Medicare has a moratorium on coverage for weight loss drugs, but there is legislation in Congress right now, the Treat and Reduce Obesity Act, that would overturn that, and it would allow access. It would allow Medicare to cover weight loss drugs. It would do a few other things in terms of expanding coverage for intensive behavioral therapy, but importantly, it would allow coverage. There's also a less discussed policy route, but the United States Preventative Services Task Force is a group that puts out recommendations on preventative services. So things like breast cancer screening and colon cancer screening and all that sort of stuff. They review the evidence and then give a grade to whether or not that service is the benefits outweigh the costs. And if a preventative service gets a grade of A or B, the Affordable Care Act requires private insurance plans to cover that service. So in the past, the Preventative Services Task Force has looked at weight loss drugs to prevent obesity-related morbidity and mortality. And the most recent recommendation was posted in 2018. And it looked at pharmaceuticals, but only gave a grade to intensive behavioral therapy. And at the time, they concluded that the pharmaceutical interventions, the side effects did not outweigh, the benefits did not outweigh the potential side effects from taking the drugs. So since 2018, several new drugs have hit the market. So there's hope that in their next update of their recommendation, that they might give a recommendation to pharmaceuticals that could trigger coverage from commercial insurance.
Alison, just a point of clarification, the Services Task Force is allowed to mandate non-services such as medical products like drugs, and is that in their charter? Like, the ACA, they can recommend a drug and then insurers have to cover that, or I thought the formularies and stuff determined, or the benefit managers determined coverage as opposed to the task force. So is that only for services, or can they actually extend to drugs?
I believe it can extend to drugs. That's my understanding, and having read the report on this, is that they can give, I'm trying to think of an example where they have recommended a drug and not just a service, and in a way, these
Anyways,
obesity.
we don't have to spend time on it.
Yeah.
I'm just curious if that, you know.
Yeah, I mean,
Go ahead.
I think it's a great point, and there's not that many examples where the recommendations do cover drugs versus services, but in the language in the current recommendation, they discuss pharmaceuticals and just talk about how at the time the available drugs did have high side effect profiles and didn't result in very much weight loss. And so that report came out before the advent, or the introduction, I should say, of the GLP-1 therapies that we're all talking about today. So it included liraglutide, which is better known as Saxenda, which is the predecessor to semaglutide, which we all know as is Ozempic, which is the diabetes. The semaglutide is marketed under the name Ozempic for diabetes, and marketed in a higher dose under the name Wegovy for obesity. And then again, the same active ingredient is used in Rybelsus, which is the pill format of this drug. So prior versions are injections, weekly injections, and Rybelsus is not as effective, but it sort of shows where the market is heading for weight loss drugs and hoping to find an oral version that is easier for patients to take. But so semaglutide is Novo Nordisk's drug, and then tirzepatide has been more recently approved by the FDA under Mounjaro and Zepbound, and it's a little bit more effective even, and marketed, it's Eli Lilly's drug. I have quickly, you can see just some of the clinical trial results, but Wegovy resulted in a 12.4% weight reduction compared to placebo in its sort of initial weight loss clinical trial. So this would be folks with obesity but without diabetes. And then more recently than that, it's been shown to have some cardiovascular protective characteristics also. So they tested Wegovy in patients with heart disease and looked at the reduction in cardiac events. And so that's the most recent Wegovy indication. Tirzepatide has had an even bigger impact on weight loss. And so in their registrational clinical trial, patients saw 15 to 21% weight loss reduction. So these new weight loss drugs really are more effective than anything we've seen in the past, which is why the conversation has heated up over TROA and some of these other policy levers for coverage. Okay, so given the new drugs and their ability to impact weight in ways that are approaching, you know, the gastric bypass surgery results and stuff like that. At the Schaefer Center, we wanted to look at and try to model the benefits of coverage. So look specifically at the cost offsets, but also at the social benefits of widespread access. And we initially did this looking specifically at the Treat and Reduce Obesity Act. So looking at what it would mean for Medicare if they allowed coverage for weight loss drugs. So looking at the cost offsets for Medicare. And we used our microsimulation model, the future adult model. And that allowed us to sort of look at different insurance coverage scenarios, whether it's Medicare by itself or looking at private insurance also, and sort of explore how the benefits of coverage varied by different population subgroup. So just quickly to step back and tell you in one or two bullets about our microsimulation model, and we can certainly go over this in the questions if people have more specific or detailed questions about the microsimulation model, but it pulls on data from a number of different nationally representative surveys. So The base of the future adult model is the panel survey of income dynamics. So that's looking at everybody in the US over the age of 25 and pulling in information on all kinds of patient details, whether it's economic or household, all of that stuff. And then we bring in information from the NHIS on health trends, and then use MEPS and MCBS to look at healthcare costs, and then bring in additional data from elsewhere. But really what we're trying to do is use these historical responses to the surveys to simulate and predict what future responses to those surveys will look like. And I think it's important to note why we use microsimulation to model the benefits of coverage for obesity. And I think there's 3 important things when, or maybe 4, when modeling obesity. And one of the first ones is that treating obesity has long-term benefits, right? So if somebody loses weight tomorrow, their medical care costs might not drop immediately. What we're really measuring is the reduced incidence of these chronic, costly conditions like diabetes and heart disease and hypertension. So we need to look more than 1 year into the future. We need to look 10, 20, 30 years into the future to really get a sense of what the cost offsets will be and what the social benefits will be. Then even beyond that, there's unique aspects to this obesity drug market in that there's a huge cash pay market. So most people don't have access, but we have probably all seen the articles that many people are paying out of pocket to get access to the drug. So if we just looked at some claims data and tried to look at costs year over year for people taking the drugs, we would miss everybody who's only in the cash pay market, which would certainly bias our estimates. And I think also important to note that even if we wait until some data source has enough data like MEPS or something like that, that would capture both the commercial and the cash pay market, we still would have a selection bias issue in terms of who's selecting into taking the drug. So microsimulation really allows us to look at what we see the current relationship between BMI and other health and economic outcomes, and use that to project what's going to happen in the future. Okay, and then just quickly to note, when I am talking about our microsimulation model at USC, this is not something that I dreamt up in my home office. This has been in development since 1999 with funding from NHIS and the MacArthur Foundation, National Academy of Sciences, and has been published very, very widely. So don't take my word for it. It's instead trust that it's been well vetted. There is a technical appendix online if anybody wants to nerd out in all the details of it. I can be happy to send that to you. Okay, getting into specifically what we modeled for the paper we're discussing today is we looked at 4 coverage scenarios. So first of all, we modeled the status quo, which is no change to what's going on right now. That's looking at low levels of coverage and just modeling people on their natural weight trajectory over time. And then from that, we did a Medicare coverage only scenario. So this is, let's assume TROA is passed, but nobody else changes their coverage plans. And what we modeled was a 20% reduction in BMI, consistent with some of those clinical trial results for tirzepatide or Zepbound. And we modeled patients getting that 20% BMI reduction and then maintaining it, but allowing some variation in BMI over time. So we allowed patients to gain up to or lose up to 5% of their post-treatment BMI. So we allowed a little bit of natural variation. And I point this out because it's just in contrast to how it's been modeled elsewhere, like in ICER and other reports. So,
Alison, there
Yeah.
seems to be a jump here that I missed. So
Medicare coverage, I guess, is going to increase utilization because you show a reduced BMI. But, you know, the Europeans' utilization is not great. I mean, their system for dealing with pharmaceuticals and other procedures and therapies is to restrict purchasing. I mean, they want to use their monopsony power. They want to squeeze the suppliers. So it seemed to me, I would say that you want to consider a scenario where Medicare coverage actually reduces utilization.
Fair point. What we're doing here is we are modeling the total benefit available if access was provided through insurers. So I think there's a lot of nuance to how uptake would happen, and we can have arguments over what the uptake rates would be, what the adherence rates would be. We've sort of set all of that aside and are trying to make a point around, you know, obesity has this huge burden on society, and
But then
widespread
seems to me-
access would have tremendous value. And then there is sort of the details of working out what the, you know, buyer's club or other setup is to allow the maximum amount of
But
access.
it seems to me you could just say, look, I'm going to simulate a 20% BMI reduction that comes from increased utilization. And then it's a separate economic question, what increases utilization? You're
Sure.
jumping to this word access. It sounds like a great word, but we've seen in practice that access can mean reduce utilization and you reduce innovation and things like that. You don't need to make that jump to use your simulator and teach us some excellent lessons.
I think
Sure,
it's,
so-
I think it's particularly important because this is the largest selling drug in the world, and Medicare IRA, the Inflation Reduction Act, is gonna go after top spenders. So this is definitely gonna be in the IRA if it comes in. And then the question is, what happens to innovation if it's included in IRA? And maybe these drugs get more utilization, but future drugs don't appear as much.
Absolutely. And CBO has mentioned in their estimates, I think it's available for negotiation in IRA in like a couple years. Is that right? I think they're modeling somewhere maybe 2028 or 2027 that it might fit negotiation. But yeah, what we're saying here is that what we're modeling, to change my language, is that patients get access to weight loss drugs once they have coverage from Medicare. So for most people, that's once they're age 65, and for people with disabilities, it's sooner than that. We've modeled all of them. The intervention is that once they are on Medicare and have a BMI greater than 30, they have access to our hypothetical weight loss drug here, the 20% BMI reduction. And we also allow, consistent with the labels for these drugs, a BMI of 27 and a comorbid condition. But so our first treatment scenario is modeling use for that patient population. And the second scenario is modeling that same patient population having access, but also private insurance coverage too. So many people are predicting that commercial insurance will follow Medicare's lead here. And if that happens, we're looking at what the benefits will be to Medicare in particular if patients have access to this drug before they hit 65. So Medicare is getting much healthier patients. And then finally, we have a universal access scenario where we fold in the Medicaid patients and the uninsured. So this is just treating everybody in the US who fits the indication for weight loss drugs. Okay, so jumping into the results from those sets of simulations, what's shown in the table here is the cost offsets to Medicare from both the Medicare only coverage and the Medicare and private insurance coverage scenarios. And so these are all modeling the cost offsets. So we're looking at the costs and the status quo and comparing them to the treatment scenarios. So what you see is that in 10 years, with Medicare coverage alone, that Medicare stands to, Medicare would see $176 billion in cost offsets. And below that, we break it out into Medicare Part A, B, and D. And that's because a lot of the conversation around budget impact has been on the solvency of Medicare. And this shows that the savings are accruing largely to Part A, which is where that conversation is rooted. And I might be getting into the weeds, but Medicare Part A is funded through the Medicare Hospital Insurance Trust Fund, which doesn't have the ability to expand its revenue source. So it's based off of payroll taxes, whereas the cost of these drugs, although we didn't model them, they will come through Part D. So there is a little bit of a financing part to coverage for weight loss drugs that will help long-run solvency for Medicare. But I think even more important than that is to notice two other things about the Medicare cost offsets. One, as if you look out to 20 years, the cost offsets grow to $479 billion, which is not just twice 176 billion, right? So it's not a linear increase there. The cost offsets are growing over time as more patients have treatment and are delaying or preventing onset of chronic conditions. It's also important to note that the cost offsets grow even more if you include private insurance coverage. And again, that's because you have more patients entering Medicare much healthier than they would if coverage was restricted until you hit Medicare eligibility. And then lower in the table, we show the cumulative health benefits, which is really like the health-related quality of life piece of all of this. And then the cumulative social benefits. And this, you see in 10 years, with Medicare coverage alone, again, so this is just getting coverage when you become eligible for Medicare, the social benefits are $1 trillion. And if we do the crude division of by 10, that's $100 billion in social value per year from Medicare coverage alone. And so if we think about that being the total value, and we need to divide that between consumers and producers or manufacturers, I think there's a lot of room to negotiate, especially if you think about the highest grossing drugs in the US are in the 20 billion range.
But Alison, I'm confused here. The health benefits are, I mean, there's a important personal element of it, but you start out by saying these drugs are not passing the market test in terms of the insurance delivery. So one slide seems to say these things are awesome for individuals, and the other slide was saying individuals aren't taking it. So how do I fit those together?
Insurance isn't covering them, right? So we're looking 10, 20, 30 years out.
But
into the
insurance
future.
doesn't think it's awesome. I mean,
No,
they
insurance.
you think it's awesome and the insurance doesn't think it's awesome. Isn't that a fair characterization?
Yes.
You mean private or public?
Private.
Yeah. Well,
Right.
they don't see the benefits if it's a long run benefit. That's the one issue. That why the private, even if it's a long run benefit, it might not be covered.
But don't they have customers who?
Well, the
Right.
thing with insurance is that you're likely to change insurance every 4 years. I think that's how long people tend to stay on their insurance plans right now. So the incentive for private insurance to cover this is low if they are the only ones covering it. And so we have that piece of all of this that we need to have widespread access before any one insurer plan can start to
Well,
recuperate.
that
the
answer
benefits
seems to
they're
say
covered.
that the benefits in this health benefit row are not really personal. Because when people change plans, they still keep their body.
Oh.
I mean, So,
The cumulative health benefits are the, these are just the quality benefits.
I know, but the people value that. I mean, and they're gonna be willing to pay for it. If it's really had benefits of this magnitude, they should be willing to pay for it, but we don't see. They're not flocking to plan and say, hey, plan, you're gonna charge X more per month. I wanna have it because you cover Ozempic. They're not doing that. Or they are, and the insurance companies haven't woken up to it, but I mean, it has failed the market test so far.
I mean, put it this way, there's some risk redistribution that takes place, right? There's some people that could not afford this, but the government taxes the rich and funds Medicare. But just think about the rich population, to isolate Casey's point. The rich population in Medicare can make a choice to do this on their own, or they can send in taxes to Medicare to do it for them, essentially, right? So the question is, if you just think about the rich population, why would this be beneficial at all when the government comes in and control prices, etc.? If they have to fund their care either in Medicare or they have through taxes, they pay a mandatory premium to Medicare, essentially, as opposed to a volunteer premium to a health insurance plan.
Yeah, but we are seeing the wealthy move to the cash
I know,
market.
but then there would be no effect on access, right? So the question is the access all because of the redistribution of the program, or like what is driving this? Because Medicare is not free. People are paying for it. So, you know, they either pay for it in the private market or they pay for it in taxes. And usually we
Yeah,
think the private market is a little bit more efficient in doing things.
Yes, and I think it's important to note in what you're seeing here is the cost of the drugs aren't in our model right now. So that's why we're not talking about value and we're talking about benefits. If we multiplied the number of people that we're assuming take the drug by the list price of the drugs, these are not positive numbers. So it's looking out at the net price right now is much lower than the list prices. And what will be the price in 10, 20, and 30 years is not known right now, but it will be much lower. And so we can jump ahead just to look at, this is the annual benefit by age on the left here. And then we'll look at it by age and BMI on the right. But this is starting to show you. So again, no price of the drug is baked into any of this yet. But we see that the benefit, if you treat somebody who is Medicare age and older, is below what even the current net price of these drugs is. And that the real benefit of treatment is in treating patients earlier in life and preventing all of the chronic conditions and other things associated with being obese. And so whether or not that's delaying or preventing diabetes or future joint replacements, all of that sort of stuff, the true benefit from these drugs is in early treatment. And also, whenever you sort of have an introduction of a new and expensive therapy, the first thing within people's mind is to restrict access and only give it to the people they think need it the most. And that's a bit of what's happening in the slide before that I showed you, is that we are looking at every person taking it. I think as we learn more about the drugs, we'll understand where the value is greatest in treating patients. But this graphic shows us that if we think about treating, I think everybody's natural instinct would say, well, we should treat the most obese patients first. And what this shows is that the people who stand to get the greatest benefit are actually those people in the more moderate BMI bands, whether that's 30, sort of between 30 and 40, the drugs make a bigger impact.
For the insurance groups here, I just want to make sure that I'm clear. When you showed Medicare and then Medicare plus private insurance, is that traditional Medicare plus like a Medicap plan or something that's supplemental, or are you including Medicare Advantage and managed care in these groups as well?
Well, so this graph is just showing, this would be sort of the universal access. This is treating everybody and then looking at the social value by different subpopulations. Back in our Medicare cost offsets table here, this is looking at everybody who has access to Medicare.
Right, but is there a difference between your Medicare column and then your Medicare, what I'm assuming, plus private insurance? Like
The
the coverage
Medicare
level?
plus private insurance includes everybody who has private insurance instead of Medicare. So that's me and probably most of you. I'm not 65. So, and I'm not disabled, so I don't have Medicare, but I have private, so I would be included in that simulation versus not in the Medicare only.
Won't the market give access? I'm not sure exactly what access means, but won't the market be giving it in about 10 years when this thing becomes generic? So doesn't the baseline already have a heck of a lot of access in it?
I think right now I've seen estimates that maybe 20% of private insurance is covering these drugs.
No, but I mean, 10 years from now, it'll be generic. So you could pay the list price, but it's going to be low.
Yes.
So that's what I'm saying. Is that built into the baseline that these drugs will be cheap, even in the baseline, once we go beyond the year 2034?
Well, I'll say it one more time, but we have no drug price in this. And that's totally the point, is that in 10 years, everything will be much lower. But even before then, we're going to get the generic competition, and we can look to previous examples, whether it's Hep C with Sovaldi when it was launched at like $100,000 a pill or something, $90,000 a pill. The same sort of hysteria around the potential budget impact of that happened. And then we had a competitor enter within a year and prices started to fall dramatically. Here we already have two competitors and the pipeline is rich. So I think the prices are going to fall dramatically before you hit generics even. So.
But that's my question, just technical. What do we mean? Simulation is always a difference between a scenario and a baseline. And
Yeah,
I'm asking, does the baseline have access in it 10 years from now? Or is that you're only turning on access in the scenario?
So the baseline is based off of nationally representative data through 2019. So the status quo or baseline is assuming low levels of coverage throughout time. So to your question, it is not turning on more access. We do have information impacting health trends, but we aren't influencing in the baseline the sort of available generic drug. So we are looking specifically at what the value is of treating obesity versus where we're at today.
Yeah, you're gonna get a too large effect relative to that effect, right? So
Yes.
the insurance coverage is gonna go up dramatically when it's generic.
Yes. I mean, again, there's limitations with this sort of simulation. We'll also have new drugs. So weight loss will probably not be capped at 20% anymore. And that whatever the next version of these drugs are probably helps you lose more weight. And then maybe some of those BMI subcategories that we looked at, shifts and stuff like that, once, you know, we can have a bigger impact on weight loss. So this is an example to show that there's value in treating obesity, and we shouldn't assume that these will still be the drugs that everybody is looking to in 20 or 30 years, but we can look out. We've done this with other therapies, sort of looking backwards, say at statins or something like that, to see how much value they've generated over time versus the cost that they've had. And so we can do this looking back in 30 years also, but we have the data we have today. So we have to sort of use the coverage that we see in the data today to project forward versus intervening and having what is as close to a cure for obesity as we've seen, right? And there's a lot of things that we have to, our simulations assume everybody's taking these drugs. Certainly that will never be the use case, right? We will never see 100% uptake or 100% adherence. But again, in this hypothetical world where let me see if I can, I'm moving my own slides and not the slides on the screen. The slides are down now, or are they still up? I was gonna go to slide 25.
They just disappeared about 2 minutes ago.
Did I do that? Anyways.
There we go.
They're back.
Okay. So again, I think we've done a good job of sort of outlining a bit of the ways in which what we're modeling here is hypothetical, and it's an example to show the potential value, or also to underline what the actual burden is of obesity, the issue of not treating obesity, what it would be costing us. So with that in mind, under these scenarios, if we look at both private insurance and Medicare offering coverage for these drugs, over time, this is showing the 10, 20, and 30-year impacts on the prevalence of chronic diseases. So we're showing the reduction, the percent decrease in prevalence. So the vertical bars are actually reductions here. And so looking at diabetes, we see that after 20 years of treating obesity, we would have a reduction. So if we started having widespread coverage for these drugs today, in 2044, 4.4 million fewer people would have diabetes, or that's the same as 45 million person years over the next 20 years, fewer with diabetes. The other part, sorry, I'm not advancing, but if we move to slide 26, because we also, as I mentioned on a few slides back, ran the universal access. So if we treated every patient with obesity scenario, these are the cumulative social benefit from treating everybody. So that's, in 10 years, that's $3.9 trillion, or in 30 years, that's $17.6 trillion. And you can see the row below it is the average annual social benefit in both of those, and all of those time horizons. But the point is really that the value of treating obesity is tremendous, or alternatively, the burden of obesity on the US is high. I think that there's also, on slide 28, we've done just a cut of the benefits, so you can see that they do vary a little bit across race and ethnic groups. But more importantly, there's also a distributional piece of this where we look at the benefits for college educated versus not college educated Americans.
Should I interpret this as a study of the value of increased demand for these drugs as opposed to Medicare coverage? Because those are two different things.
I think this is the value of treatment.
Yeah, so if we hypothetically had a certain demand for these drugs, here's how beneficial it would be in terms of health and healthcare spending. Is that kind of that's not the title of the paper though, so that's why I'm wondering.
Well, we're talking about what the potential benefits of coverage would be. Are you arguing that the demand is low for these
No, I'm
drugs?
just, the question is, what's the marginal impact of Medicare coverage as opposed to what's the impact of a certain level of demand, meaning certain fraction of the population take these drugs? So,
Yeah, I mean, the benefits to Medicare from the potential benefits to Medicare from coverage are the cost offsets that we showed on the other slide. And we have to use the term potential, right? Because we're
I
assuming
mean,
that.
no, but I mean, take the rich, like I said, take the rich population, right? They're gonna either take this or not, whether they're on Medicare or not. Okay, so there's no impact of Medicare on their utilization. There's zero impact on them in terms of
Mhm.
utilization. They're either gonna take this because they like it, they don't like the side effects, they might not take it, whatever, but it's not gonna be Medicare coverage that induces them to take anything. So zero effect on Medicare Part A, zero effect on Medicare Part B.
Oh,
Because
I mean,
they're
they would
taking,
they
because
would still get those
their
cost
demand is
offsets.
unaffected by Medicare coverage.
Sure.
So there's no impact whatsoever on Medicare because their demand is the same whether the drug is covered or not. So that's what we're having trouble with. And then you go down in the lower part of the income distribution who are implicitly getting subsidies from Medicare. And they might respond in their demand to Medicare coverage. But how do you model that? And that's sort of the title of the paper, I think, which is not clear how that translates into the numbers here.
Yeah, I would argue that not many of the Medicare age population, the demand for the drug is the cash pay market is probably fairly low within the Medicare population, but you're right in your description of what we're doing. We're modeling.
No, I mean, the title of the paper is what happens if Medicare covers this compared to when Medicare doesn't cover it.
Yeah.
And I just told you for the rich population, nothing happens because Medicare coverage is not driving their demand at all. Okay, so
Yeah, I
the question
understand.
is how far down in the distribution can you go for that statement to be true? Certainly not true for the poorest 25%. They're going to be highly affected by Medicare coverage. So
Yeah.
So the question is, what incremental impact does Medicare coverage have as opposed to, this seems to say, you know, what impact does demand for the drug have, not what impact utilization, whatever you want to call it. Yeah. So utilization.
I don't know that we
Okay.
have good data on who's paying out of pocket for these drugs. So I think your research question is an interesting one, and I don't know that we have the data to correctly model that in any way to understand who's taking it right now. And we're just starting to get some of that data.
No, but you're saying there's huge benefit by Medicare covering it, right? And I just told you a huge swath of the population when there's zero effect of Medicare coverage. So you got to take a stand on how much does Medicare increase utilization or not. And for Bill Gates, it doesn't impact whether he's going to take the drug or not. So
yeah, but what percent of the population do you think is paying out of pocket right now?
It's irrelevant to my comment. I mean, my comment is about whether the government is going to cover the drug determines whether I actually take the drug.
Yeah, my question is, your line of questioning is assuming that percentage of people who are not impacted by coverage in terms of whether or not they take the drug is a large percent of the population.
We don't know. I mean, I don't know. I mean, what fraction is
Yeah.
it? I don't know. But it's not, you know, you're assuming that
So from the time that, so I think that's changing, right? So when we did this research, starting, a year and a half or 2 years ago, I think that group was really small. And that there's also this issue that there's not even supply to really, provide all of these people with treatment, but that group paying out of pocket was small, and that there's over time increasing ways to get these drugs from compounding pharmacies and stuff like that, so that the cash pay market has increased. I don't have a good sense of how big of a portion of the population that really is.
Alison, thank you so much. We have like some questions from the virtual audience. Kira or
But maybe we
Susu?
can give her more, because we interrupt a little bit. We can give her more of the time.
Yeah, we are.
I'm
almost
happy
up.
to answer. I'm happy to answer questions
Yeah.
too. And I think like the only remaining slides are sort of talking about the fact that the value of treating obesity is large, and that we need to have conversations around how to expand coverage and access to the drugs, and whether that's different types of pricing agreements between manufacturers and payers, and how do we get to that? There's also a slide that is, in case people aren't steeped in all of this, AEI put out about a year ago or a little bit less, and used SR Health data. I think which slide is this? It shows what the average net prices are. Slide 30 shows what average net prices are for the drugs, which is much lower than list prices. But yeah, I'm happy to answer questions or discuss policy around how to pay for these drugs.
Kira? Questions from the audience, virtual?
Yeah, I can read them out, or if you all want to come off of mute. We had Joel, your question first. Are you including the dropout rate from side effects?
Yes, there's significant evidence of severe GI side effects, so much so that probably 10–15% of people drop the treatment. And this may be more severe in the geriatric population, which would obviously affect the Medicare coverage issue. Are you modeling that? I mean, for you to get the benefit of this treatment, people have to stay on it forever. And there's significant evidence that when they drop treatment, they regain, probably about half of people regain a significant part of the weight loss within a year's time. And there's every reason to think that will continue. And so are you including that in the modeling? Because if not, then you're overstating your benefits substantially.
So we aren't saying these will be the benefits. We're saying these are the potential benefits, which is the language we've used because we've made these unrealistic assumptions around uptake and continuation. And I will say that there are versions with the same simulation model that have been looking at lower weight loss and much smaller uptake, and the discontinuation piece of all of that published. This paper is not taking any of that into account. I will say the data is not there for these drugs yet. There's been a few claims data analyses, and the discontinuation rate is even higher than you're stating. So I think we just don't know yet what the future will look like 10, 20, 30 years from now in terms of how people are taking these drugs. And even since I started this particular paper to now, the weight regain has changed. That we're learning how to treat patients and help them off the drugs at the end of all of it. So the initial trials showed a huge yo-yoing impact of weight. And I think the actual use scenarios of this, physicians are finding ways to help patients come off in a less drastic way. We considered other scenarios. We measured the value if patients had their immediate 20% reduction in BMI and then returned to their pre-treatment weight gain trajectory. So for most people, that's steady weight gain through your sort of early 60s, and then people tend to lose weight once they are retirement age. So we looked at that, and the value is almost just as high in that as also sort of keeping the weight off over time. There's huge value in getting that weight reduction as long as you put the weight on slowly again afterwards. We did not model any sort of immediate rebound, because tied into all of that, there would be, I think there's cardiovascular impacts from losing and gaining weight that quickly. And so all of that stuff would be sort of guessing at what uptake and discontinuation will be and what those health impacts of gaining the weight back really fast would be. So we, with this study, tried to keep this hypothetical looking at what the total pie is in terms of value of treatment.
Thank you, Alison. We also have other questions from the audience, virtual audience. Kira, would you like to?
Jessica, do you want to ask your question?
Yeah, so I was actually curious about using BMI as the measurement tool, because there are some people who say it's kind of outdated and it's based on men's bodies and doesn't necessarily account for muscle mass. So are the benefits that you're talking about only assessing a change in BMI, or are there other health factors that you consider?
So the way that the model works is it's a series of regression equations predicting what happens to patients cycle over cycle. So it's a 2-year cycle. And so we use all the information we have on patients in terms of their health characteristics, their economic and household characteristics, their race and ethnicity and age and all of that stuff to predict what happens to them in the next model cycle. So BMI is a factor in predicting whether or not you get diabetes and heart disease and many, many other outcomes. But yeah, it is the weight related impacts in the model are all driven through BMI, but we're modeling it flexibly in splines so that it's not just a obese, not obese. So I think although we have questions as a medical community around whether or not BMI is the right measure to look at for patients' health, I think BMI works from a modeling standpoint for our simulation.
Do you know what fraction of demand is female versus male? Is that out there?
I haven't seen anything on that yet. Do you have hypotheses?
I live in Florida, and pretty much everyone I run into is a woman who takes it and not a man. But that doesn't mean men take it and don't talk about it as much. Maybe.
I was going to say the opposite here in California.
All right.
But
okay.
maybe I'm hanging out with men and you're hanging out with women.
Yeah, exactly. Exactly. It's like you know, the surgery, the fat removal surgery. What do you call that?
Maybe gastric bypass.
No,
Gastric bypass.
I haven't had it yet. Anyways, the men hide it more than the women.
I mentioned what I research, and immediately, like, over half of the people that I interact with through my kids' sports and stuff like that, then, you know, immediately are interested and talk about their use experience with it. So I think in certain affluent populations, the demand, regardless of insurance, is there for sure.
Thank you. We can have one more questions, and then after that, we have to wrap up. But Daniela, you have a question? Do you like to ask that question?
Sure, I'm sorry for the background noise. Yes, hello with everybody. I would like to ask, I remember that Medicaid used to cover the intake of orlistat like probably 20 years ago or so. So I would like to know if you have like information about it, if you have made like a study about it, like an impact study or something like that, or if you have information about that topic. And I also would like to, well, you already explained, my other question was about the estimation method. So you already kind of explained a little bit further about that. And that was pretty much it. Thank you very much.
Yeah, I'm sorry. So you're saying that Medicare used to cover a previous weight loss drug? Is that what you were suggesting? Sorry.
Yes. So I don't know if you know like the impact of Medicaid covering that.
Oh, Medicaid.
So yes, because I remember it used to cover it. I'm not sure though.
Okay. Yeah, I mean, there are
That's cryptic.
several states that have Medicaid coverage for these drugs. And I think that's sort of changing over time too. Medicare Part D has never covered a weight loss drug because it's written into the statute that it can't cover. But yeah, any weight loss drug prior to the GLP-1s has been met with a lot of I think there was like fen-phen and stuff like that that had a lot of demand initially, but the side effects were too great. And there just hasn't been a weight loss drug that has actually resulted in consistent and significant weight loss. So there aren't a lot of studies out there looking at the impact of drugs on sort of the long-term benefits of weight loss. There are studies looking at how weight impacts other outcomes, and we're looking into, you know, trying to model how the obesity epidemic has been tied to the pain epidemic and things like that. But that goes certainly beyond what your question was.
Thank you so
Yes,
much,
thank
Alison. We're going to take like a 5 minutes break, and then after that, we go to the next session with Moiz Bhai.
Thank you so much. I'm delighted to be here, and thanks to Professors Mulligan and Philipson for the invite. So I'm going to present research on scope of practice, licensing for nurse practitioners, and healthcare costs. All right, so this is joint work with Alexandra Wallace of Georgia Tech and Danny Hughes of Arizona State. All right, so this is a map of healthcare provider shortages in the United States. So if you look at the map, darker is bad. So if you look at most of the country, it's covered by a portion of the county is covered by a healthcare provider shortage area. So suburban Cook County is doing okay, like Northern Virginia is doing okay, but by the government's own classifications, much of the country is a healthcare provider shortage area. In many ways, I think of this as an example of government failure. We make these nice maps, and then we're done with it. All right, so I actually think this map is not very useful just because it shows most of the country is a healthcare provider shortage area.
Can you just for clarification define how the government defines shortage?
It's based on a number of primary care providers. So they only focus on physicians, yeah, per capita. So I think Joe Grogan and others at Paragon are doing updating the statistics using nurse practitioners.
Like the threshold below providers per capita below a certain threshold.
Yeah, a certain number, which I don't know off the top of my head. And also the county has to apply for it. So the county has to apply for it and the government designates it. Based on this map, nearly all of the counties have applied for those. So
That's for financial reasons.
yeah, exactly. And so nearly everybody applies for it. All right, so my point here is much of the country is a healthcare provider shortage area. I like this map, which looks at primary care physicians per capita, per 10,000 people. And you can see that much of the South, or a lot of the South, has very few primary care physicians. So a point of this is that when we talk about policy, we often focus on demand-side interventions. But in order for demand-side interventions to be effective, you do need to have some providers. So if you look at the geographic variation outside of like the affluent areas or areas that have like medical centers, you generally, a huge chunk of the country has a very low density of primary care physicians. This should say physicians. All right, so I'm going to talk about nurse practitioners. So when we talk about shortages in the US, this conversation is not new. We've been talking about nurse practitioners since the 1960s. They originate in 1960s concurrently with the emergence of Medicare and Medicaid. So they're an advanced practice registered nurse. So they're registered nurses with additional clinical hours and more credentials. Usually they have a master's degree or a doctor's of nursing practice. So Kaiser Permanente says that, they could perform 80 to 90% of the tasks that a primary care physician can. That's their number, but just keep in mind that there's some degree of substitutability. And they can also obtain certification and specialization in certain types. So nurse practitioners can do pediatrics and so forth. Most of their certifications are in primary care or adjacent fields. So key thing in mind is that, we don't need government regulation to identify qualities. We could have like a voluntary certification system. So why are nurse practitioners interesting? They've been growing really, really fast. So we have almost as many nurse practitioners in the country as we do almost as primary care physicians. All right, so what scope of practice? Scope of practice, I missed this one. Oh yeah. So scope of practice are regulations determined at the state level that delineate tasks and services that these nurse practitioners can perform. In certain states, they can prescribe you antibiotics. In certain states, they can't even do that. And so what's interesting here is there's considerable geographic variation in the US on what tasks an NP can perform. So historically, the literature breaks this down to independent prescriptive authority. Can a nurse practitioner give you a refill for your statin? Can a nurse practitioner give you a refill for your metformin? So in certain states, they technically are not allowed to independently do that. In other states, they can independently prescribe and then can also treat you. So in states with what we now call full practice authority, your NP can serve essentially as a primary care provider. They can see you, they can provide care, they can write referrals to you. So one thing to keep in mind is that they might be substitutes for certain types of physicians, primary care, but they're also complements. So if you go in, the NP could be like, yeah, that looks like cancer, or I'm just gonna refer you to a skin care specialist. So the AMA generally has opposed scope of practice laws, but you have to keep in mind they're complements and substitutes to physicians. All right, so this is the map for full practice authority in the United States. Illinois implemented FPA in 2021. California, I think, also implemented it. So based on where we are in the country, eventually all the states will have to adopt full practice authority. But this is the map. We still have plenty of states that have not implemented full practice authority. All right, so what is my research question? We're going to look at how state level scope of practice laws that grant nurse practitioners full practice authority, how do they affect cost and utilization for diabetes related healthcare? So the previous presentation is very useful. Clearly we're going to go there as well, but we will still need, the way our medical system works is that we'll still need somebody to prescribe your Ozempic to you and then to monitor your Ozempic. All right, so the nice thing about our study is that we have granular commercial data. So we're actually looking at people like, well, most of us who are on commercial insurance and the people on Medicare Advantage. So that's private Medicare. So it's publicly funded, but it's administered by private companies. All right, so our idea is that maybe if we look at claims data, we can unpack some mechanisms. And what we're saying is that any result that is well-powered has policy implications. If we can show that, implementing FPA has no effect or no harmful effects on the population, that makes a case that states ought to get rid of these laws. And if there's some harmful effects, then that provides a justification for why these laws should be in place. So historical evidence suggests that there are some benefits to occupational licensing. So Kofi Charles had a JPE that showed initial midwife licensing laws early in the US history, like sometimes in the 1920s. They actually did serve as a way of producing quality healthcare providers. Jason Fletcher also has one on a historical study. So historical studies show that a couple of historical studies show that when we went from no licensing to some licensing, there were quality gains, or the licensing was able to separate out or separate out quality providers. But there's also the opposite side. You can go too much on licensing. So it could be a Stiglerian story of capture, that you have too much licensing and you're restricting supply. And so our point here is the licensing a priori can have ambiguous effects. It could potentially be positive, it could be potentially negative. But depending on our results, that can kind of indicate where we are on this optimal licensing question for society. All right, so why is this important? There's a University of Chicago health policy study that came out in the Journal of Internal Medicine that talks about a primary care physician would have to spend 27 hours in a day to monitor everyone's chronic conditions. Physician burnout has been going up over time. Physicians are more likely to specialize and rather go into primary care. So there's lots of shifts going on. There's a predicted shortage of physicians by the American Association of Medical Colleges. And why are NPs important? NPs are not constrained as physicians are. So the CMS has a residency cap. Physicians generally grow at 1% a year. Nurse practitioners can grow faster. They can grow at they've been growing at 9% a year. There's still some supply constraints there, like nursing preceptors. But the key difference between the nursing profession and the physician profession is nursing has more free entry than physicians. And so the number of nurse practitioners has doubled between 2007 and 2020. And about 20 states still have these laws. So it's still very policy relevant from a state policy point of view. All right, and I'm talking about diabetes. So diabetes has a very high prevalence. The official prevalence in 2018 was 14%. And a considerable population is at risk for diabetes. They have pre-diabetes because, they're obese. And so diabetes requires continuous maintenance. And diabetics are very expensive. So diabetics experience or diabetics incur about 25% of all medical expenditures in the US. And half of those are due to the diabetes itself. So I'll just say I got this slide after watching Professor Philipson do an interview on CBS. I think you were talking about Ozempic and diabetes. So, but when we're talking about costs, you have to keep in mind, healthcare is not just about utilization and cost. A big value of healthcare is the private benefits. So it's not just that, as our study is going to look at healthcare costs, there's a huge private benefit to improving health. Good health has a value. So Becker has a VSL paper, Murphy and Topel, The Value of Life and Longevity, and Philipson, Becker, Goldman, and Murphy on how end of life, extending life at the end of life has a considerable value. So when we're talking about healthcare costs, we're looking at insurance data. But one thing to keep in mind is there's a huge private benefit to improving health. All right, so what do we know about nurse practitioners versus physicians? So Mundinger has a JAMA where nurse practitioners were compared to primary care physicians. And they find that NPs are generally provide a similar quality of care in the primary care setting. So there's another RCT, and Yang has a comprehensive lit review. Some of these are causal, some of these are non-causal. What do we know about the labor market? So what do these laws do in the labor market? So they serve as constraints. So they probably distort the labor mix at hospitals. They probably distort what kind of services NPs can provide because, they're regulated from providing these services. So generally, studies find that getting rid of these laws improves the labor supply response. So NPs are more likely to work. Part of this is how NPs are employed. Generally, NPs are salary. Physicians get paid on RVUs. So when you have full practice authority, NPs are actually, some of them can actually shift into this entrepreneurship where they're also compensated based on services provided and move towards an RVU model, where then there's an incentive for them to potentially work more. All right, so the effects on labor supply are modest, but this is one of the pathways. So one thing to keep in mind about labor supply studies is they're looking at short-run outcomes. It takes about 4 years to become an NP. So all these studies are mechanisms, but they're likely to underestimate because they don't account for the entry effects, right? So if nurse practitioners can function independently, They might open up clinics and so forth. And that's going to be captured with the lag. What do we know about health effects? Diane Alexander and Molly Schnell have a paper that shows that full practice authority is associated with improvements in mental health status, reductions in suicides. Kim Groover shows they're less likely to prescribe opioids. Professor Mitchell has a study that shows that, outcomes for diabetic debridements improve in states that implement full practice authority. So nearly all of these are diff and diff papers. So the key papers that I want to focus on is Ben McMichael's. This came out in the Journal Public that shows that states that expand full practice authority have a reduction in amenable deaths. So I like to think of this as saying, like, look, these policies are killing people. These arbitrary, idiosyncratic policies are killing people. So states that have full practice authority have a reduction in amenable deaths. And so if we believe, and we're at the University of Chicago, so if you believe in that, the value of health and life extensions matter, then this is a considerable inefficiency that's introduced into the system because of regulation. And Sarah Markowitz does a comprehensive study of medical malpractice reports and adverse action reports. So again, this is another diff and diff study that finds that full practice authority is not associated with increase in medical malpractice payouts or adverse action reports. So a big claim by people who support scope of practice laws is that they argue that maybe, NPs are not equal quality as physicians and they're not as safe. And so I think medical malpractice is one big way of looking at whether they're safe or not. And we see no changes in malpractice. All right, so pretty much most of the literature generally finds full practice authority for nurse practitioners has positive outcomes on the health side. There's one study from the VA. So this is not a diff and diff, but they're just looking at provider heterogeneity. And they're using a probability of getting assigned to an NP. So if you go to the VA at 8:30 and you're at a hospital that has more NPs versus you go to a VA at 8:30 in a hospital that has fewer NPs, they're looking at this intensity measure and instrumental variable strategy. And they find that if you're seen by an NP in the VA emergency room, you're likely to have longer stay and some higher utilization. So this is probably the closest study that finds some negative outcomes. But we have to keep this in mind. This is the emergency room. And they have a sample of 156 nurse practitioners. But in the interest of being comprehensive, there is some effect. So there's some evidence that NPs could potentially be harmful. And so this is an NBR working paper. But overall, the literature suggests that NPs generally have improved population health. And McMichael's, I think, is the most important, that shows that, changing certain laws, we could save lives. All right, so what's the mechanism? Licensing tends to reduce entry. Aaron Yelowitz has an SCJ that shows that even modest barriers can reduce entry. So part of one of the ways is that, these laws probably help more NPs come in. They're also likely to increase provider density. NPs are more likely to serve in rural areas. And NP wages are different than physician wages. They could probably support a clinic in rural Arkansas, which consists of mostly Medicaid and Medicare patients, whereas somebody who's a primary care physician, they likely don't want to go to Hope, Arkansas. The other thing is I'm going to steal Professor Mulligan's phrase and talk about business model innovations. So NPs have resulted in the rise of rural health clinics, urgent healthcare centers, and this reduces the time and money costs of getting healthcare. So they do bring in some efficiency into the system. When these laws are reduced, there's no administrative burden. So technically, a physician has to do a chart review. Physicians have to do collaborative practice agreements. So these laws, again, impose constraints. And these laws also probably restrict how a healthcare provider like a hospital can allocate talent. So if you have these scope of practice constraints, a hospital might not be able to assign an NP to a general simple case. If you go to the ER, just because you're homeless or something, it's an inefficient use of resources if you're seen by an ER physician versus potentially an NP. That's a terrible example since I talked about how NPs can do, or there's some paper that shows that NPs perform poorly in the ER. But there's a lot of mechanisms. Many of them have not been tested outside of the labor market. All right, so what data are we using? We're going to use Optum's Clinformatics Data Mart database. So this is a large commercial claims database. It has about 48 million people across 50 states in the US on commercial and Medicare Advantage plans. So we use ICD-9 and ICD-10 codes to separate out people who had claims for diabetes mellitus. So we observe every claim. The nice thing about Optum is that we see all the claims that are submitted, claims that were approved, and claims that were denied. For a subset of 30%, we also have lab data. So we have their A1C score. The CDM manager told us it's as good as everybody else, but as economists, we're always a little suspicious. Why do you have 30%? But we'll take them for their word. So we aggregate these claims to the county by quarter level, following Ben McMichael's and Hughes. So the reason we do this is not everybody with diabetes has a claim every quarter. And especially if your diabetes is well maintained, you might actually have fewer claims. And again, the key thing to keep in mind is this is commercial insurance. So people technically can leave. If they go to another employer that does not offer coverage from a CDM sponsored plan, then you drop out of the sample. So to kind of maintain consistency, we aggregate up to county by quarter, and then we calculate the number of enrollees. We also merge in data from the area health resource file. So these are some other control variables. And our data set on full practice authorities from Ben McMichael and Sarah Markowitz. And so they have the comprehensive data set. They've gone through the state statutes, and they've done a binary classification, 0 or 1. So Ben is a lawyer, so his data set generally corresponds pretty well to other data sets, and they've been more thorough. All right, so we're just going to do the bread and butter for applied micro. We're going to do a two-way fixed effects difference in difference model. So our outcomes are standardized costs. So one thing to keep in mind, so these are the costs that the insurer pays the provider. And then we also have out-of-pocket costs. So this is the copay, coinsurance, and deductible. We have some health outcomes, debridements, A1C score, number of A1C tests, primary, and the total number of primary care claims, the total number of non-primary care claims. Our key parameter of interest is the coefficient on full practice authority. We also have some event studies to kind of validate the diff and diff, and then we do the newer diff and diff estimates because of the concerns on staggered implementation and differential timing negative weights. So that literature is very fast evolving. All right, so these are our descriptive statistics. So in our data set, the average diabetic had about $2,300 of claims per quarter. So that's about $9,200 per year. So that's our cost variable. The out-of-pocket costs were about $164 per quarter for the average. All right, so these are our main results. We generally see a reduction in costs in urban areas, but we see no differences for out-of-pocket costs, no changes for diabetes claims, no changes in primary care. There seems to be some evidence of reductions in non-primary care claims, and no effects on the lab data. And so our first study was county level analysis where we don't add weights. In our second estimation, what we do is since this is county level, we weight the counties by the number of enrollees in each county. So this is our weighted regression. And we generally see the cost for diabetic care goes down by about $480, so about 15%. We see a reduction in non-primary care, no change in primary care, and generally no change on any of the biometric data.
Answer what you expect, shift away from spending. These nurses are allowed to do more things.
And they're reimbursed at a lower rate.
The fact that they shift spending away from non-primary to primary. Look at that savings.
Yeah, so we don't generally see, so again, this is not statistically significant, but the evidence is suggesting that we're switching away. But we're not making the strong claim. But yes, there is some evidence that we're shifting away from non-primary care to primary care.
MPs are gonna show up in the primary care setting, so do it.
Yeah. So that's part of the motivation is that, I mean, that was part of the motivation for the ACA as well. You're going to get more primary care, so you won't use emergency care. In the ACA case, we found out that they're actually complements. You use more of both. You go to the doctor more, and then you go to the ER both. All right, but what we see, so our biggest effect is that, you know, the payments are going down. So the payments from the insurer, or the payments that the insurer is making to providers. So that could probably reflect that they're shifting away from more expensive non-primary care services too, or just better maintenance.
Excuse me. Sorry. Hi. A question, sorry. In your claims data, do you have any demographics on the individuals who claim?
So we have gender, so this is at the zip code level. So gender, they've also, I think they run an imputation on race based on names. So it might not be high quality, but there's a race and gender variable. But again, claims is very limited. We know where they work, we know their group plan, but if they're employed, but not a lot of demographics.
Okay. And sorry, how many policy reforms were there in the sample period you considered?
So about 6 or 7 states actually changed their full practice law.
Okay.
Yeah.
No, because I was wondering why you needed the aggregation to the geographic level at all. I mean, you could literally use the panel and even potentially control for unit fixed effect, like individual fixed effect, to absorb a lot of variation that probably is driven by individual traits. That could help with power. That's why.
Yeah. Yes. So that's on the table as that, you know, just to redo it. It really depends on job tenure. So Alison pointed out that, you know, it might be like 4 years. That might be enough to observe people. Even for Medicare Advantage, we probably can observe them until they get too sick and then they go into traditional Medicare. But you're absolutely right. We could have just done it that way. And so just to be consistent with the
How does medical liability work? Is that working equally on nurses and doctors, or is it because nurses don't take out insurance premiums for medical liability, do they?
So nurse practitioners, if you're in a delegated practice state, the physician that you made a collaborative practice agreement, you're on their malpractice insurance. So if you decide once full practice is implemented that you want to set up your own practice, then you would have to get your own
This is very, very analogous to drugs where we have licensing through FDA, and then we have product liability after you're on the market. So it's a pre-market screen through the licensing called FDA in that case. And then there's a post-market penalty through the product liability. Here it's very similar, right? The licensing is, you know, you try to prevent bad service through licensing, although it also protects the incumbents or whatever, right? But also you have the liability on top of that. Now, if the liability is working, it seems to me this should be very little effect of, because the doctors and nurses, they might know good nurses, this nurse can handle this nurse is screwing up everything, we don't want to go near the patient on this topic. So they will handle that according to the medical liability that they know they're facing in some sense, right? So the question is, wouldn't we expect that under medical liability that covers both, that there should be very little effect? Because that's ultimately the incentive for them to get it right. Obviously, they care about patients, but that's the additional incentive to get it right.
Yeah. And yeah, so I think the malpractice study finds what you just mentioned, that they don't see that. So you're right, there is a kind of this heterogeneous kind of response, right? So if you're the MD, you know how to allocate your staff.
Good ones for bad ones, right?
Yeah.
So-
You're the bad ones are like, just take the blood pressure, you know?
So, but I'm wondering, like, there's obvious cost raising effects of having licenses, right? They're protecting incumbents and you make it more cumbersome for people to do whatever. But, so that's the cost side. That's like product liability in that. It's the opposite of drugs. The product liability raises drug prices a lot, but you have to worry about, getting sued for the side effect. Here, it's the licensing that raises costs.
But also there's like a Roy models type of self-selection. So if you're a regular nurse and you're like, I'm bad at my job, you might not want to invest in getting the additional credentials to become a nurse practitioner. So there's still another mechanism where you do have to take additional clinical hours. And so that probably also serves as a barrier or a screening.
All I'm saying is that there's two ways that safety is regulated. There's the pre-entry, which is licensing, and then there's post-entry, which is liability, both for drugs and services. So the question is, would you expect a pre-entry effect, which is you're saying, if we license more people, do we need to license people to do this, and do we not need to license people to do,
But we don't know that the licensing is for quality. You're just assuming.
Well, no. Yes, I assume it has
If you
some
listen-
that screening ability on,
You could assume, take this as a test of what's the licensing doing? It's distorting the allocation of tasks.
No, that's fine.
In a
I'm
way-
fine with it.
in a
It
way that
raises
creates
costs. That's
runs.
all I'm saying. It
Yeah.
raises costs.
Yeah,
That's fine.
that's what he has.
Yeah, it raises costs, but then the trade-off is the argument you said, which I think most politicians care about, and the doctors dress up as caring about. They don't care. They just want to protect. They just want to have a little competition as possible. But the politicians will say this is going to be on safety. We don't want nurses to do surgery. We all agree on that.
Yeah.
So the question is, where do you draw the line? And then that's a safety issue, but if they're covered by the product, but by the medical liability, that should not be.
No insurance company reimburses nurses for surgery,
Understand?
right? Like there's lots of barriers on that. If you're an NP and you said, I'm going to do cabbage, I'm going to do heart surgery, you are not going to get reimbursed by the insurance company for that. No reinsurance,
No
no.
one's claiming they will. I just.
But sometimes physicians say, oh, well, they're going to do surgery. Like, well, how are they getting paid by that? But that is a common thing for physicians to say on scope creep. Oh, NPs are going to do brain surgery. They're going to do heart surgery. No, they're not. They're not going to get reimbursed for that.
Yeah, that's a third screen you have
Payment.
insurers.
Yeah.
You have the liability if you mess up. The insurers don't want you to mess up.
Yeah. I mean, there are some very small surgeries, and there's actually 3 states that let NPs do vasectomies. As far as I can tell, no NP has ever done a vasectomy.
But yeah, I was gonna ask if you have, in these examples where states opened up, did you have any insurers in those states say, we are not reimbursing if you have the MPs involved in X?
I'll have to look into that. That's a good point. But you're right. That actually is another screen, right? The insurer actually ultimately decides who gets reimbursed per procedure. So I think Steve Parente has a very interesting paper on CRNAs that are nurses that are specialized to do anesthesia. So in states where they're not reimbursed, surprisingly, they don't do that. But in states that are, then they will supervise it. So that's a good point, and I will think more about that. Actually look into whether insurance, how insurance has responded, and if they've generally
In some
covered.
sense, in-house, they did a study like you did. But they're using it for commercial purposes.
Yeah, I'm sure. Yeah. So just to kind of go with the flavor of the month in econometrics, we've done the additional estimators, and again, our costs showing up. So these are the unweighted regressions. So generally, we observe reductions in costs, the standardized costs, and we see some evidence of reduction in non-primary care. We also do event studies. Again, the way as you mentioned, the way we've done it is just that, it's 3,000 observations since we've aggregated up. So you see these big standard errors. So we separate them out by urban and rural. So all 3 estimators. Again, this has fallen out of fashion in the last 6 months that I've done it. I think the rule is now you should show them separately. All right, so these are out-of-pocket costs. They're just wide standard errors, but you don't see any parallel trends. All right. So keep in mind that this study is only looking at commercial data, right? So this does not, to go to Professor Philipson's point, a lot of times legislators care a lot about what is it going to do to Medicaid costs. Because I think once you get sick after you're 65, they're like, you're the federal government's problem. So this excludes the Medicaid population. And if you're cash paying, then you're clearly not in, right? So if you're cash paying for all your services for some reason, you're not in. All right, so keep in mind, this is a short run study. So long run outcomes might be better if if there is actually substitution. And if there's entry. So this is relatively cheaper than typical government plans, because government plans usually cost a lot of money. So when we talk about policy interventions to improve access to care, again, so I say improve access to care in terms of increasing the number of providers. So interestingly, I think this policy is interesting because it causes distortions in inputs and outputs. It causes distortions in the labor market. And it can potentially cause outputs. It could cause distortions in the health markets because, we have fewer providers, fewer services. And I'll end with Professor Mulligan's point, just because you have an insurance card doesn't mean that you get seen, especially if you live like in a rural poor county. So conclusion, we need to also think about supply side. So that NPR study was focused on increasing reimbursements. Look, physicians already work like 55 hours. Increasing reimbursements is likely just a transfer to them versus actually getting them to do more. So there's tons of studies. The FTC wrote one. There's policy pieces in the New England Journal of Medicine. So this is generally a low-cost intervention. And this is likely a $20 bill that we have in the state policy sphere, but we can't pick it up because regulation costs are like $30. So I'll end with that, and thank you so much.
Thank you. I don't know if this mic is on, but I hope everyone can hear me. My name is Katina Latham. I actually teach a course here, but I'm also a director of the healthcare team at GAO. So I think this is a very timely work. I just wanted to provide some context for you to think about as you move forward. Just on the, as you mentioned, increasing the provider supply and, elevating the role of an NP would certainly help. But I think you should also just make sure you note the challenges, as you point out, with the nursing shortage in general, post-COVID, and just the availability of nurses. And in fact, nurses now don't even want this role. And that most of them are moving, a lot of the NPs in particular, wanting to move more towards administrative work. So just something to bring into that context that further challenges the availability of the nursing supply, which I think would be helpful.
Yeah, I think that's a good point because Mitch testified in Pennsylvania, and that was the argument that the AMA had put out. It's like, well, if you let nurses become nurse practitioners, we already have a nursing shortage, so we shouldn't do it. Right. But so that's a good point. And I think that just tells us that, we have bottlenecks, we have constraints because there aren't enough preceptors. But yes, noted.
I'd be curious to hear you elaborate. You said there's an interest to shift toward administration. So what's the thinking? Is it compensation or lifestyle or what is it?
Lifestyle. I think just like everyone else, they want to be able to work remotely. They want more flexibility. They don't want to sort of be tied to providing the bedside patient care.
All right. Thank you.
This talk is, I'm just going to sit here. It's kind of a lunch talk. So, but it's going to be a little bit different from the other ones in terms of I'm going to discuss some of the things I'm doing instead of studying innovation or healthcare innovation, we're actually executing on some of it with some companies involved trying to launch new initiatives. But it kind of falls into the category Casey mentioned before, which is that we spend very little time worrying about the supply side relative to how financing is done. And if you look at health economics in general, a lot of it is about who pays and how much, as opposed to how can we stimulate essentially new innovation, which ultimately is the thing I think that I haven't measured it, but my guess would be a priori that's really what matters in terms of improving health for people, that kind of innovation. So many times what's good for financing purposes are not necessarily good for innovation purposes. And that clash is many times not recognized, I think, in health economics. So innovation essentially always, and the things I'm going to talk about today as well, you can think of always sort of lowering costs and make health cheaper that otherwise was more expensive. So when you hear people saying that brand name drugs, brand name drugs are actually cutting prices more than generics are, because brand name drugs make the health enabled by that drug essentially cheaper, many times more than generics, lowering the price of the drug. So if you think of my favorite example would be HIV, you couldn't buy a longer life anywhere on the planet if you were HIV positive in 1995, but then the new innovations came on the market and you could purchase that longer life with the brand name innovations. So innovation in disguise many times is cost reducing, even though it might increase healthcare spending. And certainly there's a lot of evidence in the health economics literature that innovation is the source of a lot of healthcare spending growth. But for the price of health, essentially, it's always reducing the cost of better health. Now, I'm going to talk about two efforts I've been involved with, which deals with AI innovation, artificial intelligence, which is also just another way of lowering costs by raising productivity, essentially. And so this is not a discussion about how to study AI innovation, essentially. Just going to talk about how has this been executed in two areas that I've been involved with as a product developer, essentially. And it might suggest certain research around that, which I think would be very interesting to do. So the first area concerns a new product that's going to ensure clinical trials. So clinical trials is about 2/3 of health or medical R&D spending. It's phase 1, 2, 3 for drugs. And it's a big component of that spending. And I've developed a product for Lloyd's of London, which is the world's largest insurance conglomerate. And they will now launch a product this month that will ensure the clinical trial cost if the trial fails in its endpoints. So you have a breast cancer drug, let's say, and you spend $10 million on the trial, and then it turns out there's no longevity effects of compared to the treatment group, and then you get your $10 million back from Lloyd's if that turns out the case. So this is an insurance of a biological risk, and this is very important because that's something that insurers, it's a very good risk for insurers to insure. It's a biological risk, but it's just telling you how the molecule basically responds in the body. We're not insuring business expenses or anything like that, or management issues. We're just ensuring the outcome of the trial, whether it means its endpoints or not. And it's a good risk to insure because it is completely uncorrelated whether we have a recession in the economy, et cetera. So it's, a beta zero, if you want to think of it that way. So the rest of the balance sheet is not correlated with this coverage, essentially. It's also good because within a portfolio of insured drugs, one drug failing doesn't determine or influence whether, a cancer drug failing doesn't influence whether the Alzheimer's drug is failing. So it's independence within the portfolio, which is very attractive for insurers as well, as opposed to, let's say, if you have a loan portfolio and you have a recession and everyone starts defaulting at the same time, that's a correlated claim in the insurance. Here you have uncorrelated claims when you have separate biological risks being insured. So how would this work? Well, suppose you have a biotech, like I said, that has a $10 million clinical trial it wants to run, and it takes out insurance. Now, these trials have high failure rates, right? So that's got to be reflected in the premium. So let's say this drug class has a 40% failure rate, in the sense that 40% of trials entered into don't meet their endpoints or have a successful outcome on their endpoints. So for that purpose, let's say the premium is $5 million to insure a $10 million trial. The reason that's valuable, there's sort of, if you just think of that straight insurance, and I'll talk a little bit about how you can finance around that. But now you can essentially, this is very attractive to philanthropic funders of medical or product develop or drug development, such as American Cancer Society or similar institutions like that. Because they can now, instead of funding a trial for $10 million, they can buy insurance on 2 trials for $10 million. Remember, the premium was $5 million. And therefore launch 2 efforts as opposed to 1, because once the drug company is covered in the insurance, they can go to their investors and say, I have a premium on the failure of this, or I have an insurance on the failure of this trial. If you invest in me, you're going to get your money back when the trial fails, and you get your upside when the trial succeeds. That's very attractive much more attractive for investors than at 40% of losing all their money if the trial fails. So the disease groups are very interested in this kind of coverage because it increases their kind of bang for the buck in getting medical innovation done in some sense. So this is, in some sense, this is, financial innovation to stimulate medical innovation, and disease groups are front and center, I think, in terms of using that type of insurance to get more activity on their funding drug development. But even without a disease group, suppose you are a biotech and you're trying to raise money for a $10 million trial, you can now go to your investors and say, I'm going to raise $15 million instead, but once I fail, you're going to get 2/3 of your money back because the trial costs are insured, the $10 million. So invest in me because you have some downward protection in your investment when the trial fails, essentially. And that's going to be an easier raise for the biotechs if they're covered. At least that's what they're telling us. We'll see when it launches. So that's the straight insurance, just the straight insurance on the trial itself. So, and Lloyd's have committed about $1 billion to cover, in coverage for that kind of clinical trial insurance. Another big US PE firm, private equity firm, has committed $1 billion to lend against that insurance, meaning, okay, you have an insurance on your trial. We're now offering you a loan. So you have a $10 million trial. We're going to lend you $10 million. If your trial fails, Lloyd's is going to pay us back because you're insured. So the loan is secured essentially with the insurance in that case. And we're going to charge you, for a loan that's secured a lot less than for a loan that's unsecured essentially. So there's a big value of having debt financing for these biotechs are usually very scared of debt financing because once you have debt, you're going to go bankrupt if the trial fails. So you have no money and you have a debt, and that's the end of story. You're going to close your shop. So this allows them to be basically forgiven for their debt once the trial fails. It's going to cost them, obviously, but they're going to be forgiven for their debt. And then they have less dilution when they do well, meaning they're not holding equity. They didn't give up as much equity that the funders, typically the VCs, take a big share of their company, up to 60 to 70%, to fund their trials. And they avoid giving up all that, the whole store, by having debt as opposed to equity. So that's, so this product will basically, the insurance will be basically lending itself to a debt forgiveness instrument, if you want, by the lender. And that is also sort of part, the first part was just straight insurance. This is kind of a secure debt related product that will also potentially help biotechs keep control of their company. Now, how does AI? I said I was going to talk about AI. There's a company called GATC that I'm also involved with. GATC is the 4 letters in the DNA. And they're a California-based company that's going to underwrite this product for Lloyd's, essentially, meaning determine the risk. What is the risk of this trial actually failing or succeeding? And they have the market-leading technology, essentially, on on predicting whether molecules are going to work on a particular drug target. So that AI is essentially enabling this financial innovation to take place, because without that AI, it would be not enough margin for Lloyd's to issue this coverage. Essentially, that's how they make their margin, because the AI is better than the average risk in the class of predicting failure. Now, the question for a group like us, or for a research group, would be, which would be interesting to address, is how much, if at all, would this stimulate medical innovation if you had insurance against biological failure in that innovation process? That's something you could probably get funding from Lloyd's to do, essentially, to figure out. But it is an important component, because ultimately this financial innovation, like I said, is built to deliver more medical innovation. And the question is that true? And to what degree can that take place when you have this insurance? So I think that's kind of illustrates, a real world product that kind of came. I've actually proposed this product a long time ago, 2015. And then I got sidetracked with other work. But it is a real product that I think, comes out of economics training and thinking a little bit more about the supply side rather than just the payment side in some sense. So that's one set of how AI is essentially enabling new financial markets currently through the GATSI underwriting, which is instrumental for this product to essentially be launched. We couldn't do it before. The second product is a little bit less complex, which is, this is a company called iRemedy, and it's one of the architects of Amazon Marketplace is now going into the medical supply space, and he has designed essentially a platform whereby which manufacturers of medical products, whether it's drugs, devices, or what have you, can essentially interact directly with providers, hospitals, and doctors, essentially, without a middleman. So that's kind of what Amazon does in the first place. They cut out the retailer. So here the effort is to do that in the medical supply chain. And who are the middlemen, as well as the giants like McKesson and Cardinal and those guys, who are essentially the middlemen in the medical supply chain. By the way, McKesson's CEO is a Ph.D. econ student here at University of Chicago, Brian Tyler, who was in the same cohort as Casey and me back in the days. So he's pretty old, as you can tell. But he's an interesting guy. So the iRemedy's purpose is to make Brian Tyler lose his job, essentially. But that's the goal. That is essentially the goal, to have one less step in the medical supply chain, essentially. And I'll talk a little bit about one of the main efforts, which is to help, trying to help. We're in discussion with Lilly on their obesity drug, which was mentioned here in an earlier talk. Obesity drugs, I'll do a little side show on obesity drug, because the co-author Richard Posner and I predicted about 25 years ago that sooner or later medical innovation in obesity will be far more successful than so-called preventable behavior, or diet and exercise, in reducing obesity. And it's actually and it will be innovation. We predicted if this drug comes to market, is by far the largest drug, and it is now by far the largest drug we've seen. And the reason is because the prevalence of the disease is so high. So it's a huge market. It's a huge incentive to innovate. Therefore, people have tried for a long time, but now finally we're getting treatments that are working. But obesity is kind of like many other diseases where we think that, you know, if we just had the right behavior, we could sort of solve this problem or reduce the prevalence and incidence of the disease. And it's so cheap to do that, that, you know, we shouldn't need to take pills or whatever if we just behaved correctly. But it's very costly for people to change their behavior, it appears. That's why we have an obesity epidemic, essentially. But it's true for many other diseases. HIV is the same thing. Like, so if you believe biologists, they think we're here to do two things. One is eat, and then two is to spread our genes through sex. So HIV is the sex component, obesity is the eating component. It's very hard to change those behaviors. It's very inelastic, if you want. And medical innovation has by far been cheaper than behavioral change in limiting the impact of those types of diseases. The primary example for that is, I think, COVID. COVID could also be prevented if we just all sat at home. It's very costly. The economy took huge hits in foregone economic activity when we did that. So behaviorally, it can be prevented in principle. It's very, very costly. Compare that to the maybe a few tens of billions spent on medical innovation that generated vaccine and therapeutics. And that's a much cheaper form of prevention through innovation rather than behavioral change or lack of face-to-face interaction. So that's kind of the poster drug or poster case for why innovation is many times more often cheaper than behavioral change in actually limiting disease. So Eli Lilly has, you know, these drugs are now enormous as predicted. There's like these are huge markets given the prevalence. Novo Nordisk in Denmark has a market cap of 555 billion. Compare that to Denmark's GDP, which is about 400 billion. Essentially, one is a wealth measure or present value of future income as opposed to GDP, which is a flow measure, but to give you some indication of the size of these drugs. Lilly has a market cap of 725 billion, enormous. Compare that to Pfizer's, who at the peak of COVID, when they had the best vaccine and the best treatment, had a market cap of 325 billion. So these are enormous drugs because of the prevalence of the diseases. And what iRemedy is trying to accomplish is to have a direct distribution. Lilly has actually set up a direct distribution already. It's called Lilly Direct, very indicative name. And by which you basically go through telemedicine to get access to these obesity drugs as opposed to go to your own doctor. So you basically log in on Lilly's webpage, and then you get assigned to a telemedicine office that can basically have a doctor talk to you. And then you can get prescribed that way to cut if you want, the intermediary steps between, manufacturers and patients. Through telemedicine, they're essentially limiting that cost. A lot of the cost of obtaining a drug, many times it's not necessarily the dollar cost, it's time cost involved in seeing a doctor, etc. And not only Lilly, but Pfizer and other companies are very interested in using mechanism to go directly to the patients as opposed to, or more easily go to the patients than, physical meetings with doctors, etc. So iRemedy, this AI, sort of, if you think of it as the Amazon marketplace for medical products, is very involved to try to help Eli Lilly do that. The research here, I think, is more about thinking about how direct distribution of medical products directly from manufacturers to patients can impact, the value in health generated from that. Given that a lot of times the cost of healthcare is not dollars, but time. how much are you generating in better health by having sort of lowering the time cost of care, if you want, from these direct distribution systems that are going to be put up through the AI. I think that's something that I don't know if we have studies on time costs on, adherence and initiation of certain drugs, etc. I think those studies exist there, but I don't know if we have studies on sort of in the general distribution scheme, if you get access in your home as opposed to traveling to see a doctor, how much impact there are studies of travel distance in healthcare, how much that lowers utilization. So if you can electronically travel to your doctor as opposed to physically travel to your doctor, that is certainly going to be, according to that evidence base, it's going to be important to improve your health. So that gives you two examples of sort of companies who are in the middle of this in terms of using innovation to improve healthcare. And I'll be happy to take any questions about it or talk around it, what you think are useful sort of research questions raised by this. And because I think AI is going to have an enormous impact both on medical innovation, not necessarily through this insurance, but in general, because we're getting much better in predicting drugs without doing clinical trials, essentially. And the huge cost of developing drugs is the failure rate and time involved in very costly testing of drugs. And also in the supply chain, I think AI is going to have an enormous impact on lowering the cost of sort of accessing healthcare, not necessarily through a high remedy, but in that space, that's going to be an important component. And we already seen it. It's sort of weird. We needed it in some sense for telemedicine. We needed a big pandemic to tell us how valuable it was. But I think now people are understanding that it went well beyond, infectious disease to realize the value of having less time consuming if you want healthcare. So I'll open up the floor to any questions or suggestions.
Just a question about what you presented. The iRemedy, they're distributing. What does AI have to do with that?
So it's the AI platform. So if you look at Amazon Marketplace, there's a ton of AI. I'm not an AI expert, obviously, but there's a ton of AI that goes into matching customers to manufacturers and getting that distribution, or getting a catalog of thousands of things to actually work in terms of sending stuff. And that's the same with if you have medical products on one, or you have manufacturers. It's not different. It's just medical, that you have the Pfizers or the medical device companies on over here, and you're trying to reach a customer over here. There's a lot of stuff that if you did it manually, it would just completely break down. You couldn't coordinate it manually.
So it's an upgraded search engine.
I don't know what you want to call it, but you can't do it manually because the time involved. I mean, you could do it manually, but it would take, it wouldn't be so beneficial because it take forever to set up every crate if you want. So it's all, in fact, iRemedy is developing agents like customer service operators that are AI, not people, who will then ask you, certain questions and then feed it back to the patient, et cetera. So this whole coordination problem wouldn't be feasible with just people involved sitting in a, warehouse. It has to be automated.
So I think probably, yeah, so Professor Philipson mentioned that the cost of clinical trials is like 2/3 of all the innovation. So maybe we can think about to use can we use the existing clinical trial data to like help us to like refine AI models to to build on the existing clinical trial data of other drugs to help us to develop or like innovate like a new
What
drugs.
they do, they train the AI on past clinical trial data a lot, but the whole purpose here is to basically not have a huge year-long or many year-long process by which you essentially find a drug. So the AI can find a drug. In fact, this ECCHC company I mentioned, they have developed their own drugs with the AI. Say, here's the molecule we develop, it's going to be working, and now they're going into animals. It's working exactly as predicted. That doesn't translate into humans yet, but it's amazing that they can predict in the animals. And this is not coming through any kind of petri dishes at the lab. It's just coming off the computer that they developed that molecule, essentially. So therefore, they can do this much quicker. They can develop 10 drugs a year this way, right? Easily, as opposed to that would take an enormous amount of time to do without AI development. So they're not alone in this space. There's a lot of people, not a lot, but there's like 5 firms that are sort of leading in this space, roughly. But you're going to see that they not only do they predict whether a given molecule is going to work, they're also developing new molecules off the AI, which is going to speed up the whole process.
So you use the AlphaFold, like the AlphaFold of
what?
So we have like AlphaFold. Is that like that? Some chemical molecules. So they are searching for some
I didn't
called
understand.
AlphaFold.
I didn't understand the word.
Yeah. So that.
Oh.
Yeah.
Okay.
I think
See that this, demonstrates that I don't know enough about AI, but I just know the result.
Okay.
The key is the result here. So here's the result that hooked me on it. They had UC Irvine chemistry department send them blind molecules and say, does this work or not? And then they had the AI run it. And they were right 80% of the time. Now compare that to drug development, where a given drug class in phase 1, 2, 3 fails 50% of the time. So you're wrong 50% of the time. Here they were wrong 20% of the time. That's a huge leap in performance in terms of reducing the cost and resources spent in trying to get drugs developed.
Okay, thank you.
I have a question. So normally clinical trials will take like 10, 15 years to complete and sometimes more based on the evidence from ECCHC. How shortened can we complete
You still
those?
have to do the trials. That's the thing, right? So,
Okay.
But this will increase the success rate. So if you look at success rates now, phase 1 is about, I think it's like 60% of drugs go on to phase 2, and then it's like down to 40 or 30% from phase 2 to 3. And then it's another 25% or something that actually makes it to approval to FDA. So from start to finish, it's about an 88% failure rate, essentially, which is massive, right? So that what you're trying to do is to reduce that failure rate from what's called an initial new drug application, which is before phase 1, until going to market, to reduce that failure. You still have to show to FDA that this works in humans, right? You're not going to be able to sidestep FDA because you're doing that. So you still have to demonstrate that it works. But the name of the game here is to not, the reason you hear this estimate that it costs $2.5 billion to develop a drug, that's not for each successful drug that reaches the market. That's taking account all the spending on the 88% of drugs who didn't make the market. So for each successful drug, you spend $2.5 billion, but that includes all the failures to get one successful drug, essentially, right? So if you look at a clinical development program for a drug, it might be 100 million or whatever. But you failed, 88% of the time with that. So essentially, that's what's attempted to get reduced, and also to get the new molecule quicker. It's a long time before you actually have a molecule, before you even start in animals. But what this effort is involved in is trying to get that much quicker done. So you can start animal testing.
So I have a question about the question. So why
Hey, what?
for the in-person market for the R&D, it was not there before.
Correct.
But people don't assess the rate of the.
Well, but that's true of any insurance market that you don't know. That's the whole thing you're trying to insure. Like, so you buy car insurance, you don't know whether you're gonna crash or not, right? So the whole purpose of an insurance is to kind of limit your downside when something bad happens, and we take a haircut, the premium on you when it doesn't happen. In some sense. So that's the same here essentially, that an accident for a clinical trial is a failed trial, and you're gonna take a haircut when the trial goes well, meaning you pay the premium for this, but now your company is worth, 10x what it was before the successful trial. So it's, you take a little bit off the top to make sure you don't lose all the money on the downside.
Yeah, so I think so the risk is there, and I think it makes sense that the company should do that before. But the market was not there before, so why? Because they cannot get the rate of failure of the child, or.
It might be the underwriting, because if the insurance company is going to charge you a margin on the risk on 50%, it becomes 60-70%. That's 7 cents on the dollar, or 70 cents on the dollar. So it might be that the underwriting is what made sort of this fly in some sense, because once the underwriting and you're putting down the risk to 20% when you insure a trial, you can deal with that.
But I think he's asking what's new. This failed the market test all the way up through 2024.
Which failed the market? I don't think people have tried it.
These products, he says these products haven't been around until.
Yeah.
Yeah.
I've been telling Tom the story about Milton Friedman thought there should be trade in CPI futures. And they went to Merck and they started a pit and nobody wanted to trade it and it had to close.
Yeah, I mean, we have a market, so it might not be demand, certainly, But as far as anyone in this industry, I don't think they would have brought up, we tried this before, and they haven't. But like with any new product, you don't know if it's going to work until it's, until people start buying it.
Yeah.
There's new insurance product launched every year. So does that negate that? I mean, innovation is innovation, right? So question is, when you have new products, does that mean the market did something wrong before you had a new product? Not necessarily. This is just financial innovation as opposed to, you could say, why wasn't there a drug to cure obesity 30 years ago? People were fat 30 years ago. Right? So, if you bring a new drug to the market, it's because of the innovation. I think there's a lot of innovation in this financial product that couldn't been done without, I think, the AI.
So that's where AI comes to. Without AI, people become too, because they cannot assess the risk.
It helps with the underwriting, right? It helps with the underwriting, yeah.
Yeah, I agree.
Hi.
So for a lot of diseases like Parkinson's, cancers, there are tons of clinical trials and they can train models on these, right? But for rare diseases, right, where you don't have lots of clinical trials, for you to train on, because
that's a very good point. I mean, it turns out half of the FDA pipeline is cancer, actually. And people are very interested in that. I mean, it's obviously a huge, I think it's the second biggest killer or something like that. But it's also because cancer therapies is mostly in the old population in Medicare, and Medicare pays very strangely for physician administered drug, which many cancer therapies like chemotherapy, et cetera, are. Because they pay, as you know, probably that they pay a certain percentage of the drug cost gets paid to the doctor for administrating the drug. So, you know, it used to be 6% or whatever. So if you have $1,000 drug, the doctor gets more. 6% of 1,000 is a lot more than 6% of 100. So there's a very perverse incentive in Medicare Part B drug sales, or physician administrated drug sales, if you want. So that's an issue, and that's where most of the cancer population sits in the 65 plus. So a lot of what FDA is seeing is oncology development, both because it's an important disease, but also because it's physician administrated, and you basically have a customer who likes higher prices. Very few markets are like that. And that's kind of a screwed up government way of doing things, but that's the current state we're at. Essentially, the doctor wants a higher price drug because 6% on a high price drug is more than 6% on a low price drug. So, but you're right, coming to rare diseases, then you have less data to train on. So the AI is definitely better on cancer than it is on rare diseases. Any other questions?
There's a question in the chat online. David, if you want to unmute yourself. Or I can read it as well. Is anyone researching the barriers to implementing AI innovations? It will be seen as a threat to physician income in primary care, radiology, pathology, dermatology, and other physician activities where reimbursement can be affected. For example, it has taken decades to change medical practice acts to allow nurse practitioners to enter the direct care market. What can academia do through its research to facilitate more rapid achievement of AI benefits?
So I think Grogan's gonna deal with policy towards, if I don't.
Yeah, that's perfect. That's a great,
That's a great lead into to Joe
Right.
Grogan. So you wanna, Joe Grogan and I worked together in DC for a while. And he used to be the director of the Domestic Policy Council at the White House. And now is a USC Schaefer Center, I believe. But he's also in London, which explains the remote access to the conference, essentially. Joe, take it away.
thanks, Casey and Tom. It's great to see you guys again, and I'm sorry I can't be there. This has been great for me to participate in. I'm so glad you're doing a conference like this. I hope this is the first of many, and I hope it really takes off, and more academic institutions that are focused on healthcare will have conferences like this, because they're to the point when Casey kicked off. It's too much of the debate is about who pays and how to get quote unquote coverage, and not how to get people care and treatments. So I've got a few slides here to talk about the AI policy landscape, because I think this is a real opportunity for young researchers, young scholars to really dig into, because it's, per Tom's conversation, it's we're at the beginning of this product development, and we're really at the beginning of a massive shift in regulatory policy as far as the federal government is concerned. Okay, so these are the working principles. This isn't a product of a huge ratification body, which is probably why they're pretty good. But this was a informal group of right of center healthcare policy thinkers that got together about 6 months ago. And to be honest, at the beginning of this flurry of AI media attention and regulatory attention from the Biden administration, and frankly from Europe, I live in London now and split my time between London and DC. And Rishi Sunak here and the European Union as well has been very focused on AI regulation. Tech issues can be very complicated, and I've got a lot of other complicated areas of healthcare that I'm focused on right now. So it wasn't something that I was champing at the bit to get involved in. And I kept on waiting for some leading right of center thinkers and private sector actors too, innovators, to step forward and try and push back on the dominant narrative that was being portrayed in the media that AI was terribly scary and this was going to lead to a Terminator-like Armageddon, and only the federal government and a hyper-regulatory environment could save us from the dangers of AI. So a group of us got together and came up with some loose principles to guide our thinking, like, hey, is this what we can agree on as a starting point? And then we can work on how to address this. So at the beginning of the year, there was a lot of talk about, oh, we're going to need a new global agency in the federal government to run AI for the entire federal government and be a master regulator. This is sort of a stupid idea because there's all these different federal agencies, right? And AI applied in transportation, applied to the Department of Commerce, applied to the Department of Homeland Security or the Defense Department is going to be different than applied to the Food and Drug Administration or the Centers for Medicare and Medicaid Services. So our first principle was we don't need a new regulatory agency. Interestingly, some people, some scholars and researchers we spoke with said, no, we don't want to commit to that yet. We may want that down the road. But for the most part, it was agreed that for the people that stayed in the group, we came up with this idea of a no new regulatory agency. And I think it's going to become clear in a bit why that's important. So that any regulatory framework should boost research and development and safeguard intellectual capital, not devalue intellectual property, not devalue research, not threaten eminent domain, and not threaten to take AI development products and development away from the private sector, or outlaw them before they're able to be developed. A key point, I think, that the woman mentioned just now about the barrier to entry with doctors not wanting there to be certain expansions of practice of medicine, scope of medicine requirements for people, for say nurses, because it threatens their bottom line. This is a key fear of mine. Before I was a domestic policy advisor, I was what's called the Associate Director for Health at the Office of Management and Budget, and very focused on healthcare spending and how much the federal government spends on healthcare. When we're at, about $1.7 trillion, when the beginning of the Trump administration was about 1.2. There's been a huge explosion in healthcare spending, both by COVID, but also due to Biden administration and the Democratic Congress's expansion of healthcare spending. So we spend a lot on healthcare, and we don't want it to be cost additive. Typically, what happens with the new technology is doctors, for instance, if they're doing a surgery and they're getting reimbursed because they use a cost schedule at the Center for Medicare and say, okay, we're going to pay you X for a knee replacement surgery to a Medicare patient, and then a new technology comes on, and in the private sector, it should reduce costs. But what happens is the doctors will go in the lobby and they'll say, hey, wait a second, this can't affect our bottom line. Give us an additional payment, which is one of the reasons why healthcare innovation doesn't bring costs down frequently, as it does in other sectors. Education and healthcare are the two areas where innovation does not bring costs down, unlike everything else, unlike air conditioning and food production and televisions and automobiles. So we want to be disciplined about figuring out how AI can both reduce costs and improve efficiency. And government should abstain from dictating outcomes or limiting scientific debate. I mean, this is a key factor that in our opinion needs to be focused on. as we saw during COVID, there was far too much limiting of scientific debate among leading researchers in the private sector about how the virus was spreading. There was leading researchers were silenced, they were blackballed, they were pushed off of social media. Casey and I did a talk together about his book, and we were deplatformed off YouTube. And it was just nuts. I don't know what it was we said that offended people, but we were deplatformed at one point, and that was a minor incident, but there was like serious scientific debate that was being silenced. And it's already happening in the AI. There's so much conversation at the federal government about we can't have algorithms that lead to uncomfortable outcomes and results. And we need the government to make sure that the results are quote unquote approved. And it's sort of a scary moment, I think, in terms of scientific debate, because you can't have science without debate. You can't have advancement without debate and an open discussion. The regulations should not be overly complex, and we need to make sure that they are clear and that innovators know how to comply and what they're up against. And regulators should consider the impacts of regulation on innovation. Far too often, the federal government doesn't contemplate what a regulation is going to do to stifle innovation, to dry up capital. So if we could, let's see if I can go to the next one. There we go. This is great. So there's already currently a number of different ways that AI is being regulated. It's we've had machine learning in a number of different products for years, and FDA has been regulating machine learning products for many years. If you just look right there at number 3 with the FDA, they under their authority from the Center of Devices and Radiological Health regulate diagnostics and devices if they are to diagnose a disease, then they're technically under FDA authority. Now, frequently they don't always do that. Frequently they'll do enforcement discretion, or you'll see advertisements on TV that if it's not FDA approved, there's language that just skirts this line and says not intended to diagnose, but really, they're sold to for people to be able to choose them if they want, to help them inform their decisions. Your Apple Watch was a long-standing debate at FDA about how much regulatory authority they were going to exert over pulsometers and oximeters on the Apple Watch, and a number of these other things. And when I was at the FDA in the Bush administration, we were talking about regulating anything with an algorithm because we were worried about the black box. Now, ultimately, we refrained from that. We were not hyper regulatory, but there was a lot of debate, and there was a draft rule that went all the way to the White House and was discussed for months about whether or not it should be debated. And then a very restrictive rule was just issued by the Biden administration that encompasses these algorithm-based devices, but it's much broader than that too, to encompass all laboratory developed tests. And then, at the Federal Trade Commission, they have rules about honest claims about capability. So you can't lie and sell somebody something that says this device is fueled by artificial intelligence and it's going to tell you how to pick stocks perfectly. You're going to be a millionaire in 6 weeks if you buy this product. HIPAA, of course, is at HHS. That's data privacy for your health information data, and they have swept in a lot of AI-powered AI tools under their regulatory authorities. The 21st Century Cures Act requires different devices to be interoperable so you can move data back and forth. And then the Office of the National Coordinator, which is sort of interesting, this regulates health records. Was a big priority for the last decade, was to make everybody go to electronic health records. The Office of the National Coordinator sets the standards for electronic health records if you're in a federal program. That market is now dominated by just a couple providers, frankly, Cerner and Epic. Epic Systems is a privately held company. Cerner has subsequently been bought by Oracle. And all the big providers are on one of those two, and increasingly more with Epic. And that both of them use AI-powered tools in there to help inform doctors about what they should be looking for, whether it's, hey, this patient might be at risk for a heart attack, this patient might have an infection, things like there's a whole bunch of decision support tools. And this is a question for regulators, right? Is this diagnostic, or is this informing the physician that and the nurse that they need to be aware, they need to be concerned and use their own judgment to look at this. Don't miss this. Make a conscious, rational decision to check for sepsis, or to check and make sure that their sodium levels are appropriate. And the Office of National Coordinator is moving into this space pretty aggressively. They just issued a rule here. They'll be asking for more resources. That's what federal agencies do. They have a mission. They determine that mission is not ambitious enough. They move in to get to take over more regulatory space, and then they go to Congress and say, hey, listen, we have even more things to do, when nobody's asked them to do it. Congress did not tell them to issue this rule, but they'll be asking for more money, and they'll say, we can't administer what the territory that we have just claimed without more federal resources. So there'll be a whole bunch of new demands on taxpayer dollars in the federal government if trends continue as the regulatory bodies want to regulate in this space. Interestingly, the Office of Personnel Management just issued a rule that allows a massive bonus for AI engineers to be hired in the federal government. Off the top of my head, I can't remember whether it's 50% or 100% of salary, but that bonus could be at the top of the federal pay scale is around $225,000. So you add 50% on top of it, or 100% on top of it, to recruit AI engineers, because they're so in demand. And there aren't enough going around in academia and companies, let alone the federal government. So they're really scrambling to hire more AI experts and engineers. And the big one is the Biden administration a few months ago issued an executive order on AI. It's 110 pages. The point person for this is the Deputy Chief of Staff for Policy at the White House. 110 pages is a massive executive order, by the way. It's the biggest one ever issued, and it's breathtaking in its ambition to regulate in this space. And it has unleashed a fury of rulemakings coming out of various agencies, working groups, meetings in this area. So the two competing visions for AI, I would suggest.
Joe, can you do you have a little bit more granularity on the executive order as it applies to healthcare? I mean, is it all healthcare, or is it wide?
No,
yeah, exactly.
It's everything. Yeah, it addresses everything. There is a lot of focus on the need for regulation in this space, a lot of concern around equity, a lot of concern about the potential for bias, a lot of concern about the abuses that could result in the harms. Now, to their credit, they do talk about the opportunities that AI is going to present. They do talk about the fact that it's an important technology that needs to be advanced. But on this slide, just as I was about to say, when we developed the internet, there was a conscious decision on the part of regulators in the United States, policymakers, excuse me, in the United States, that we were not going to regulate it with a heavy hand. We were going to let it unfold, but in the marketplace, and the United States was going to dominate this area. And sure enough, that's exactly what happened. And a lot of credit goes, in my opinion, to Democrats and Republicans for allowing it to run the way it did. And it was an innovation. It was a remarkably libertarian ecosystem from the time it was really started to take off through the Clinton administration and beyond to recent times. However, a lot of people don't like what it became. And a lot of people think that it was the wrong approach and think that the government should have taken a harder line early on and required more regulation out front because it's led to bad outcomes. On the right, there's concern about what it's done for brain development, what it's done for certain things like the promulgation of pornographic content on young people and adults, the sale of illegal drugs in many parts of the internet. You can buy guns on the internet illegally. You can buy all sorts of stuff on the dark web. You can buy, there's human trafficking that takes place on the dark web. And there's all sorts of things that occur on the internet that if you're not using it the way people are using it in their day to day, it can lead you in some very dark corners, which concerns a number of different people. But on the left, there's concern about, hey, look, and I think they're quite open about it, too much speech. There's too much allowance for quote unquote disinformation, too much allowance for false content to be presented as real. And we made a real mistake in the United States by allowing the internet to run as long as it did without a heavy hand of regulation. And there is an emerging bipartisan consensus that's worth paying attention to for more regulation in this area, including regulatory changes to some of the insulation from the Section 230 protections that the internet companies get from lawsuits. So the debate right now is between that original libertarian salvation principle that defined the internet development versus the precautionary principle, which is where Tom and I really began to know each other when we both had a relationship with the HIV manufacturer, Gilead Sciences. In pharmaceuticals, FDA doesn't let you go out there and say, hey, we'll see if this drug works. And the marketplace decides. They make you go to the FDA, prove that it's safe or effective. They verify that it's safer. There's going to be trade-offs. There's going to be side effects, but they say on balance, it's more effective than its side effects. Every drug has side effects. It is on balance, provides value to society. It has positive health effects outweighing its risks. We're going to allow that to be marketed. And the precautionary principle is dominating now in the executive branch, the regulatory construct, the approach on AI regulation. For the most part, agencies are relying on existing authorities. The reason for this is the Congress is totally dysfunctional, and number one, and number two, there's no consensus anyway. So it would be really valuable to have Congress weigh in and work through a policy process about how we should regulate AI, but that's not going to happen anytime soon. And I've got news for you. Aggressive agencies can find legal authority to put a rule out there and claim regulatory authority over emerging technology. That's a big issue right now. The Supreme Court has a pending decision where they're evaluating whether or not how much deference the regulatory agencies get in the executive branch, absent explicit statutory designation of regulatory authority in specific areas. That's the issue is around Chevron deference. I don't want to get into it too much, but that's going to play out this year. That decision will come down before June or in June, before the Supreme Court breaks. And that's going to have a big effect on regulation writ large, including in healthcare, but in this area specifically. And there is a ton of stuff going on in the States, a ton of regulation going on with state regulation in AI. There's hundreds of bills that are being proposed, working their way through committee, that there's very active activity at the states. And there could be a patchwork of state laws that force the federal government to get involved in it, but that is not going to happen over the next 12 months, I don't believe. So a couple, facts here. They're not perfect, of course. You're building algorithms. You're going to have problems with things going wrong. And this is an early technology. Obviously, we recently saw the debacle when Google unleashed their Gemini AI tool, which was somewhat an embarrassing release for them as it gave crazy results. There was an incident in New York where a law firm was using artificial intelligence to help them with research, and they filed a submission to the court, and the AI tool had invented court cases. And the law firm had to apologize. They didn't review it closely enough. They put too much faith in the AI, and they got in trouble with the court for submitting a false filing. So you can have things go sideways on you with these if you're not careful. So I don't mean to say that this is not a fraught technology or that we can just trust that everything's going to be perfect. There are going to be growing pains. Now, a recent development that I find very fascinating and is worth your time to check this out is the Coalition for Health AI, or CHI. This is a new group that formed in the last few years, and they are set up opposite an outfit called the Health AI Partnership. Now, these two groups were set up to help figure out how AI should be regulated in healthcare. They were funded by a think tank out of California, from one of the early IT innovators in California who made $1 gazillion and set up a foundation. They were both set up on competing tracks. How do you think this should all unfold? And they have ended up in divergent paths. I would suggest to you that the Coalition for Health AI is playing the Washington, D.C. game brilliantly, while the Health AI Partnership may be more sound on the policy and the reasoning and the science, but they've gotten outgunned on the DC game. CHI has in its coalition Google, Microsoft, MITRE. MITRE does a lot of consulting for the Department of Health and Human Services. And they have developed this assurance lab concept. And the concept is that, say, Tom, and one of his many lucrative investments in the private sector in artificial intelligence, wants to deploy an artificial intelligence diagnostic tool to improve patient care. He's going to send that with his company to a quote unquote assurance lab. Google is partnering with the Mayo Clinic, and they're going to take the data and they're going to take the algorithm and they're going to figure out whether or not it works. And they're going to give it its stamp of approval or disapproval. Now, Google is developing its own health artificial intelligence products, and so is Mayo. And I don't know another circumstance with such an obvious conflict of interest. Compounding this, the board is set up of federal regulators, including employees of the Food and Drug Administration and the Office of National Coordinator, which I mentioned earlier, which regulates health records. And the executive director is an employee of MITRE, the health contractor that does a lot of contracting with HHS repeatedly. So that's one model that they've adopted. Congress isn't paying too much attention, and reporters haven't paid too much attention, which I find fascinating on this, because to me, it's like one of the great hustles in DC lobbying to be able to set this up with a board set up of private sector and public sector regulators. And the other thing that's fascinating to me is if you go through Google's history of trying to deploy healthcare products, it's like a murderer's row of disastrous defeats. Like they have never, ever, ever succeeded in healthcare. They continually get their ass kicked. They announce some big thing, they move in, it gets a lot of media attention. Then they have to wash out on it. They have never deployed a successful product. Mayo Clinic hasn't either. They have tried to commercialize products in the past, and ultimately they're a hospital, and they have failed too. Now they've figured out how to get involved in this, which is to turn themselves into the regulator. FDA has authority to grant third-party entities regulatory authority. At this point, they have not said they're going to do that with these assurance labs, but it's on the track to do it. They're trying to get more buy-in, and they're trying to get more momentum here before they're going to do it. But it's clearly on the track that the assurance labs want to be FDA validators for this technology. And then the Health AI partnership, their vision is, look, it is moronic to take your data and send it off into out of where it was gathered to a third-party validator that has no idea for what purpose it was gathered, doesn't understand the clinical context in which it was gathered, doesn't understand what it's going to be used for, and separate it from the patients whose health it is supposed to employ. So one of their examples would be, look, if you develop an artificial intelligence tool to improve patient care at the Veterans Hospital in San Diego, and you send it up to Minnesota to the Mayo Clinic and Google for them to validate it, blind, they don't know why you were developing this, and they don't fully understand your patient population. So some of the members of the Coalition for Health AI have written on this in the past, the need for local validation. It needs to be validated in the field where it was gathered and developed, and where it is going to be deployed to improve patient care. And the safeguard being, to go back to that example of the clinical support tool, it keys something to the physician and the nurse. It tells them, be on the lookout for something, but the physician and the nurse is ultimately the clinical decision maker, and then you're validating it as you're providing patient care. That's their vision for it. And their interesting point, because the assurance lab concept gets wrapped up with a lot of equity arguments, is, look, the surest way to defeat the goal of equity is to take it out of the clinical setting and move it into the abstract realm in an academic medical center. So it needs to, because you're dealing with a sick, diverse population on a local setting. If it's being developed in San Diego, but you're not dealing with a similar population, hypothetically, in Minnesota, where it's being validated, and you don't understand the ethnicities, you don't understand the racial bracket, you don't understand the cultural, the socioeconomic. You're validating something without any understanding of the clinical environment in which you are trying to say whether it works or not. And again, the conflict of interest, I think, is really quite stunning. This I referred to, I mentioned this before about this black box issue, that so when I was at FDA, I'll just give you this example because it's almost 15 years now that we were dealing with this. 15 years ago at FDA, you would have, when we were exploring regulating, the example was a breast cancer diagnosis. So somebody develops a laboratory developed test that purports to say the likelihood of let's say the most persistent form of breast cancer. And that could inform, if you presented that to a patient, she might say, okay, I'm going to get a double mastectomy. But what's the reason for this? Like, what are the triggers to say this, to provide this clinical decision? And say, oh, well, the algorithm said it. We put the factors in, we took a blood sample, we took a history. She was diagnosed at 42. She's at stage 4, yada, yada, yada. But you don't know the variables. And at that point, the issue we were dealing with is people were developing laboratory developed tests, which were not regulating at FDA at the time. And they were bolting on these very sophisticated algorithms. and they were in some cases selling them across state lines and all this stuff. But it was a very sort of scary concept, as you can imagine, that there would be an algorithm that nobody understood what it was in it, how it worked, and patients might be making really drastic decisions about their health based upon that. So you needed some type of visibility into what is in the black box. And this science is mind-bogglingly complex. I'm in the process of working on a white paper at USC on this, and I've got an incredibly smart young researcher working with me, and like the variety of models being developed, the sophistication of them, how these things are operating. Every week there's some new hint of some new development somewhere. And of course, there's a lot of things going on in research areas that we have very little visibility into it. And then another issue that we need to think about is copyright of the data. Data isn't just data. If you're making sense of data, if you're scrubbing data, formulating it, putting it into an order, whether you're an accountant taking data, and then you become, say, E-Trade, and you're saying, well, yeah, I've got the data, but now I've scrubbed it, I figured out what the good data is, I put it into all these algorithms, I'm helping people pick stocks. Somewhere along the line, that data is copyrightable. Now, is it in the accountant's office, or is it when the accountant becomes E-Trade? And this is going to be a big issue. This is going to be a big issue as we move forward, because data is so valuable. I was recently at a conference where a very famous venture capital person was saying, data is in so much demand. There's talk in Silicon Valley about building robots to just go out and be aware and gather data. And it's one of the reasons why Tesla is valued the way it is, and why it has so much enthusiasm. I know the stock has taken a hit over the past year or so, but it has a tremendous amount of value in there because of the data it's gathered from people driving, about how they react in situations, but about roads, about geography, about all sorts, how other people react. And all that data feeds into their artificial intelligence product development and can be sold for other products too. But it could go anywhere. I mean, they could develop anything with that data. And just to flag, the Copyright Office is going to be issuing a report to look at the copyright law issue related to AI and data. I think it's supposed to be the end of this year, but it could be, it could slip, but I think they're going to want to get it done before December. That's their target, because they want to get it done either before the end of Biden's term, or if he were to lose the election, they would definitely want to get this report out before, so they'll move forward. And I seem to have lost my ability to, one thing to think about here is the reimbursement for AI, as was alluded to in the question right before I started talking about. The other thing to think about this is how much waste can be saved. I mean, it is astounding how much waste is done with tests that didn't need to be done, services that didn't need to be created. So you can really reduce, the potential is there. The potential is there to really reduce spending in healthcare from a federal government perspective, including flagging for fraud. 360 billion is probably an understatement, but when you layer it into the private sector as well, not just fraud and reducing paperwork, for instance. I don't know if anybody's experienced going to the emergency room lately or being in intensive care, but the physician comes in or the nurse comes in with an iPad, doesn't look you in the face, or your friend in the face, or loved one in the face, but is looking at the iPad when they ask all these questions, entering data, and then leaves. Well, if a physician or a nurse could come in, and they're doing this now, but as a matter of course, you had it all voice activated, and the AI could incorporate that data, they could make a connection with the patient, really understand what they're going through, their symptoms, because there's too much depersonalization going on right now. It makes patients very uncomfortable. They're frequently not truthful in their answers, and they're not as forthcoming as they could be. This is a example of just some of the AI fueled tests. Sorry, my dog is barking in the background. Just some of the AI fueled tests that have been developed lately. And you see that APC stands for the ambulatory payment classification. That's a Medicare term that they use for reimbursement. So they're granting these additional payments for the technology. I'd like to see them figure out a way to reduce the overall payment and get cost compression here and not increased payment. I mean, Tom was great, so I'm not going to beat this up too much on its applications and how it's going to revolutionize things. But he mentioned all the opportunities in drugs and devices, and I mentioned health records as well. Just to get back to this program integrity issue, there's so many improper payments that go out of the Medicare agency. I mean, it's just insane. And the same thing with Medicaid. You see these headlines, if you pay attention, to massive amounts of improper Medicare and Medicaid spending, or Justice Department swoops in to some organized crime syndicate that had figured out how to bilk Medicare. And you're talking tens of billions of dollars in some instances. AI could really help clamp down on that. And synthetic biology, which is a really fascinating field where we're figuring out how to use the tools of engineering in the biological context to build things through human reason, but AI could really help increase this as well. Things which would have tremendous environmental positive impacts too, if you're able to engineer organisms that then grow what you need, whether it's leather for automobile seats, but then they'll decompose at some point, or replace plastic bottles with a compound that is biodegradable over time. And let's see, I'm thinking we're almost done. I'm not going to beat this up too much because Tom talked about the drug developments, but AI is going to be fueling more at-home care. This is a trend because people want to be in their homes and hospitals are too expensive. But making a human being available to provide advice and intervene and say, oh, we need to send an ambulance. This person is in trouble in their home. They need to get to the hospital now. They're having an acute event. AI can really help do this. The UK data, it's interesting, but I think we're so new to this right now that it shouldn't really be extrapolated to say that AI can't help, because this is such nascent technology in this space. There are a lot of risks, as I alluded to it. You can have different types of errors, including, for instance, if you try and sail from London to Savannah or Miami, you're off by just a little bit at the beginning. By the time you think you're in Savannah, and you're actually up in the Arctic, because your starting point was just a little bit off kilter. You can really get the wrong results with bias amplification if your data set is not big enough. And that has been a counter argument on a lot of developers to this concern around algorithmic bias, which is to say the solution to getting biased results is just a bigger data set. Of course, if your data is all white males or white women who from upper socioeconomic group, you're going to get different healthcare results than if you were going for a more diverse group. So you need to include, depending on what you're looking at, if you're looking at white women in that instance, and you develop an algorithm for their treatment, fine. But you can't extrapolate that. And it needs to be labeled and understood. Where did this data come from, and what was its makeup, and understand for the purpose in which the AI product is being developed. The same is true if you want something that's broadly applicable. You're going to need a broadly applicable pool, and you're going to need a very diverse pool. You can get these model hallucinations, like I mentioned with the legal filings, where the AI tool invented cases that didn't exist, that were clearly convincing, until one of the paralegals at the court started to look into them and realized that the cases didn't exist. And model collapse. I don't want to spend too much time on how all these things can go wrong, but if you're not validating your model with sort of, I'm trying to think of a good analogy here, but like a pace horse, or an outside a shotgun model, where you're validating it with other results in your algorithm and taking your data set and putting it into a different algorithm, then if you don't have a way to an external validator, then you can have this situation where the model collapses over time because it's validating itself. And of course, but doctorate and fraudulent research is always a problem in any type of research or product development, whether it involves AI or not. The defense to this is just not to give the AI product more deference, in my opinion, than any other science that you're not fully aware of. So, doctors frequently prescribe medicines. They understand the basic chemistry. They understand the disease progression, but there's a lot of things about that drug that they don't understand. And frankly, there's a lot about why drugs are effective in certain instances that even the developers don't understand. But the drugs are given, and then if there's a side effect that's not listed on the bottle, human reason intervenes. The patient, the doctor say, hey, wait a second, this thing is making me break out in hives. And it wasn't seen it's not on the label. There's nothing in the clinical research, but this patient is having a side effect. Let's take him or her off the drug. And then maybe there's a confounding factor, and they go back on the drug after a few weeks and see if the side effects persist. But the point I'm trying to make here is that you can't just turn off human reason with these things. You can't just say, oh, well, the algorithm told me this, the black box told me this. We are still in a development stage. And this tool of Tessa was a program for weight loss advice, and it was giving the absolutely opposite advice to people about what they should be doing to address their eating disorder. I mean, it was bizarrely inaccurate.
Eat more and exercise less.
Yeah, I mean, it wasn't, it was even for people that were like anorexic and bulimics. It was giving, or obese. It was just giving terrible advice, like what you would not do. Like, and of course, some of these people are in pain as they're trying to figure out what to do with their diagnosis. Now, I don't think this thing is exhibited to actually have caused human harm, because the results were once deployed, they were so obviously crazy. I don't know of any instances of people actually following it, but somebody developed it, thought it would work, and it didn't. But the results were transparent, right? And people were able to say, okay, it's suggesting this, and this doesn't make any sense with our clinical experience and with common sense. I mean, loss of clinical expertise as providers increasingly defer to AI. This is a concern of mine. Frankly, I used to be awesome reading maps, and I drove across the country all sorts of times before the advent of Waze and Google Maps. And I can't drive down the street anymore without Google Maps. I mean, I can't drive 10 minutes without slapping that thing on to help me get from point A to point B. And not many people can anymore. frankly. So the danger is people will get a lot reliant on AI, and then we will lose clinical expertise and the judgment that comes from doctors and nurses, the judgment that comes through practice over time. And of course, this is always a problem with data. There's going to be hacking. This stuff isn't secure right now. There's a lot of talk about making people put it all in the cloud. Interestingly, this is one of the things that Oracle's doing in their Cerner acquisition. Oracle stock has been on a tear because they've really bet on the cloud. And one of their reasons for this is to enhance data security, that it's not going to sit on somebody's hard drive. It's going to be securely locked away in the cloud.
So Joe, are these risks the ones the executive order goes over, or is this your risks that, because they're concerned with other risks than these, right?
Yeah, I think you would say these are objective risks.
But they're not the risks that are the concern of the new 100-page executive order.
Right. I would say they're adopting the precautionary principle, and they're worried about a lot of things that have yet to be borne out. Now, the rhetoric, to be fair, the rhetoric in the media with you turn into Fox News or CNN and they've got Arnold Schwarzenegger from the Terminator and stuff. I'm not going to say that's what the Biden administration is doing, but there is so much concern about the risks and focus on the risk in that executive order. And in Europe, including in England, saying, no, we can't allow this to be, AI is going to hack into all our banks. It's going to be able to launch nuclear weapons when we aren't paying attention to it. It's going to shut down people's medical devices when the AI program decides that their life isn't worth it anymore. All these things, these parade of horribles that are being discussed. And of course, racial bias is a big thing in equity. There's a lot of concern around, is this going to lead to enhancing discrimination? And some of that is justified. I mean, big organizations historically have used sophisticated tools to discriminate at various points. And the question is here, are we going to guard against that? Are we going to be aware of it? Are we going to try and address it? Or are we going to say, we're going to trust the regulators to do it? And I'm not all that fired up to trust the regulators, because regulators frequently have people who are not culturally aware or maybe biased themselves. And I think this is a common problem for all of society to address. And if we do it transparently and have open discussions about it and make sure our data sets are big enough, I think we can address it.
Were they mainly concerned with equity issues in the executive order, or are there are these national security issues, or like and how
national security issues are
addressed?
addressed. Yeah, national security are addressed. Equity is a big part of it, that it's only going to be available to the rich. It's going to enhance the gap between rich and poor. It's going to lead to tremendous displacement in the workforce. And a lot of the unions are concerned about this. And Joe Biden has made it clear we're not going to fire anybody in the federal government because of AI. It's going to be enhancement. One question would be, though, why should we adopt that? I mean, maybe we don't need as many people working for the federal government. The federal government does a lot of people working at the FDA, perhaps, could review things more quickly than if they had a decent AI tool to spot certain issues and evaluate data themselves. They could get through more applications, but maybe they also wouldn't need quite as many employees at the agency. That's just one example that I know you care about.
Joe, there's a question from the virtual audience. David, would you like to speak up? Can you unmute yourself?
Yes, thank you very much. Joe, you mentioned earlier in your presentation about Epic and Cerner in the electronic medical record space. And I wanted to just say that Epic is really dominant in this space, particularly because they're in the larger hospitals and they're in virtually all the hospitals that train physicians. So that nearly all the physicians now are being trained on Epic. So Epic is going to become more and more powerful, more dominant in the industry. when it comes to this AI technology, they serve as gatekeepers. Nobody's going to get into a hospital with new AI technology without going through Epic. And my concern is their interest, they have a business interest in giving preference to technologies where they're going to get a bigger cut of the revenue, number one. And number two, they're going to serve the economic interests of their clients, the hospitals and doctors. And right now they're focusing on getting in these nice technologies that are going to assist doctors in doing notes and a whole bunch of things. But when it comes down to technology that's going to start affecting income of the doctors or the hospitals, their incentive is to protect their clients' economic interests. So here's a private company. What are you going to do to get their incentives aligned with the interest of patients?
It's a great question. It's a big, it's a big discussion. I mean, who owns the data and who can get access to it? Does the hospital own the data, and are they going to be able to partner with innovators to use that data to develop products? Epic's dominance, it didn't happen overnight, which is the interesting thing. I mean, they were the small player for a long time, and they've, blown everybody out of the market, not through acquisition, interestingly enough, but just driving people out of the market and more hospitals choosing them. There is talk about cracking the hospital data open, including Epic's data, but I think it's a question. I mean, Epic develops the system, they rationalize it, they make it useful. Data isn't just data, and say, oh, well, you made sense of the data, I want it now. The other thing to consider is, from my perspective in this whole context is, and the federal government should put its data out. The federal government has, if you want to put data open source and convert data into open source, have all the CMS data out there, have all the NIH funded research data out there for everybody to see. And yet the federal government husbands a bunch of this data. And we need, if before we go into the private sector and say, look at all the work you did to rationalize this data and make it theoretically marketable or turned into a product, we should be doing that with all the federal government data. Instead, they're making it harder. And they're making it harder to get at CMS data, which has been kind of controversial over the last year. They're charging more, and they're gatekeepers. Not anybody can get it. You have to prove to CMS that you have a quote unquote worthy purpose and that you're the right type of researcher to get access to their data. CDC has a ton of data. I mean, I would argue, frankly, CDC needs to get out of the business of publishing their research. No CDC employee should be able to put their name on any research, because they fund this research and then they sit on it for 2 years until the CDC employee gets to punch it out. And that should be public information right away. It should be turned around very quickly and pushed out and help product developers use it if there's a value in it. So Dave, I think those are all great questions, and the where all this data is, which is why, I mentioned the Tesla example, but data is like water. It's so important. It's like, or oil. It's so valuable. And it is the big question probably in all of this is who owns the data? When do you require it to flow? When do you push it out there for common development?
Go, we're speaking from Chicago, and guess what? In Chicago, the criminals don't obey the rules. Just us chumps, who are law-abiding.
I think that's the nature of what a criminal is, regardless of whether they don't obey the rules.
I think that needs to go into one of your warnings about regulating AI, because who's going to have to follow the regulations? Us law-abiding people, but the fraudsters aren't going to follow the AI rules. They're going to be, unconstrained, and so we'll lose the race even to criminals if we're constraining, the law-abiding sector.
I think.
Because
I think
you were
national-
optimistic about the fraud, like, oh, we're gonna use this to beat fraud. No, the fraudsters are gonna use it to beat us.
It's fair. No, I think it's true. And there are these scary examples of AI products that can take my voice. Like if somebody's on this phone recording it and knew what they were doing, they could call my bank when this conversation is over. And try and get my accounts and things like that. I mean, that stuff can be done. I do think we need to be worried about national competitiveness though, too, and national security writ large, because there is a ton of money in the Middle East flowing into this space for research and development. There is a ton of money in China flowing into this. And the example I would use is we have a competitive advantage when we rely on innovators and competitive spirits in the free market. We are not the best regulators in the world. You know, other countries are better at regulation than we are. We don't have that tradition. It's not in our blood. But when we're wide open, we win. And we can win this race, but not if we adopt the precautionary principle and say that every AI product is going to can only proceed without the express blessing and approval of the federal government. We need to encourage people to develop in this space.
Questions? Okay, so that concludes the program. So I think the overall theme has been here, which Joe was kind of at the end of, is this value of considering and thinking about more carefully than we currently do on how supply impacts healthcare as opposed to how financing impacts healthcare. And one of those areas has been the increased productivity of supply, particularly in AI, and the regulation of that new productivity, which is what Joe was talking about. But I think this is going to be kind of an ongoing theme of the center, I think. So if you guys have any research or proposals, etc., and that you want us to consider in that area, feel free to. Casey and I are always available just to, talk and shoot ideas around. And if you have interest in that area and talking to us. But I think I'd be surprised if next year we're not sort of stressing the same theme of this year, maybe in a slightly different beta version than this year. But thanks everyone for coming, and happy to have a discussion afterwards as well. Thank you very much, and those people online as well. Thank you.